रजिस्टर करना है मीडिया वाला जो टीवी या पूरा दिन उधर अर्चना को बोलना, अर्चना देगी, क्योंकि हमने क्या किया मीडिया को बहुत आ जाएंगे हाँ सर भी बैग दो ये दो चालू करना है पहले जो रजिस्टर करना है जो क्रेडिबल मीडिया है दे देंगे
Namaste. Good morning. It is wonderful to be here in Ahmedabad, Gujarat. We want to welcome all delegates to the 16th National Conference of the AIDS Society of India, ASICON 2025. Much effort has gone into preparing this scientific agenda, and we hope that it will be a good scientific fest for all of you. We've tried to include in this scientific agenda the latest updates in the field of HIV. On day 1 and day 2, the sessions begin with free paper presentations by our young scientists and researchers. The two plenaries for day 1 and day 2 are long-acting ARVs in HIV treatment and advances in biomedical prevention. Of course, there are sessions on HIV epidemiology, co-infections, comorbidities, malignancies, and other infectious pathogens. We have clinical presentations and case discussions between postgraduates and clinical experts. We have a debate on self-testing. We've included specific sessions on women living with HIV, children, adolescents, and young people living with HIV, and key populations. We've also included cross-cutting issues such as climate change and its impact on HIV, and of course, artificial intelligence and its use in healthcare, especially in the field of HIV and other infectious diseases. We have included a session on cybersecurity and cybercrime in healthcare. So we hope that you will find these 3 days of the conference extremely useful and that you will go back with a sense of satisfaction and fulfillment. Thank you. I now hand over to Dr. Kumarasamy.
Good morning, everyone. So you heard from Dr. Glory about our packed agenda. Now, on behalf of AIDS Society of India and the Governing Council of AIDS Society of India, we welcome you all to our ASICON 2025 to this wonderful city of Ahmedabad. Again, we have a very packed agenda. Again, thank you again for coming. Also, at this time, we welcome all the faculty who have come from Gujarat and from our neighboring states, pan-India, from across the globe and across the continent. Thank you again for being here and welcome to this conference, ASICON 2025. At this time, I will introduce our local co-chair, Dr. Harsh, to welcome you all. His traditional style.
Good morning all. Namaskar. Welcome to Ahmedabad for this 16th National AIDS Society of India Conference. You will have a wonderful time for exchange of knowledge and discussion. We will have an interactive session throughout the 2 days. The last day you will have side topic subjects which are of great importance in medical field, as Dr. Glory has already told you. We will have 2 days evening cultural programs, and you will definitely enjoy the famous Gujarati Garwas and folk dances by the group that we have invited. And you will have a very good climate weather in Gujarat or Ahmedabad and have a nice wonderful stay here. If there is any problem, you can contact our local team, committee members who are around us all the time. Welcome all once again and enjoy your stay. Thank you very much.
So let us begin. We welcome the co-chairs for this first session to be here.
Thank you so much. I would like to invite Dr. P. Narendra Singh and Dr. Uday for the first free paper session. I would like to call upon our first speaker for today, Mr. Chopa Surya Neville. And the topic is an instance of recurrent fever, abdominal discomfort, and multi-system symptoms in a patient with advanced HIV disease.
Respected doctors, professors, and my colleagues, good morning to one and all. Myself, Chopa Surya Neville. I am presently intern in pharmacy in the College of Pharmacy. So today, my topic is on an instance of recurrent fever, abdominal discomfort, and multi-system symptoms in a patient with advanced disease of HIV, which is a case study. So in good introduction, HIV has impact on the immune system. HIV attacks CD4 cells, weakening the immune system and increasing susceptibility to the infections. Without it, it progresses through stages, eventually leading to AIDS. Importance of managing co-infections. Opportunistic infections like progressive multifocal leukoencephalopathy and microbacterium avium complex can greatly complicate the management of HIV and instead the targeted treatment. So object of the case report is to underscore the diagnostic and treatment difficulties of MAC and histoplasmosis in HIV-infected individuals and stress the necessity for a multidisciplinary approach. Background: prevalence and co-infections. Co-infections such as MAC, histoplasmosis, and TB are the common in advanced HIV cases, with global estimated indicating a high burden in immunocompromised population. The prevalence of TB was found to be 16.29%, and in the year 2021, there were around 0.60 million individuals who were co-infected with HIV. The incidence of histoplasmosis and MAC was found to be 5 to 25% and 20 to 40% respectively. The case overview. The case report details the diagnostic and therapeutic challenges of a 33-year-old male patient with HIV presenting with recurrent fever, abdominal discomfort, and multi-system symptoms. The patient experienced multiple hospitalization and underwent extensive diagnostic evaluation and treatment. Challenges in HIV diagnosis. Immunosuppression complicates the symptoms, presenting often requiring extensive imaging, histopathology, and microbiological analysis to confirm diagnosis. Impact of treatment outcomes. Delayed or missed diagnosis results in extensive hospitalization, reduced the quality of life, and complex treatment regimen. This is a summary of the case. So initially the patient who came with hospitalization with the symptoms of fever, abdominal pain, and night sweats, then the symptoms attributed to the typhoid and dengue, which are eventually treated. But even though after treating this dengue and typhoid, still the symptoms are persistent. So then doctors asked for advanced imaging and lab order, which CT scan, CT scan, ultrasound, laparoscopic, and urine test. So as you see, this is the symptom progression over the months, which red, blue, and green indicates fever, abdominal discomfort, and night sweats. As you see, as the months increases, the symptoms keep on increases. Until the 12th month, when they diagnosed correctly, then the symptoms severity was decreased eventually. Diagnostic evaluation. CT scan finding shows an lymphadenopathy in the para-aortic region and right iliac lymph nodes, suggesting possible granulomatous infection. Featuring favors microbacterium complex lymphadenopathy. CT scan findings. It showed mild hepatosplenomegaly, multi-compartmental abdominal lymphadenopathy, and moderate ascites, which indicating systemic involvement. Liver enzyme abnormalities. Elevated liver enzyme and low serum albumin acute jaundice, complicating tuberculosis treatment. Microbiological and histopathological results. Urine histoplasma antigen test was positive. FNAC biopsy confirmed microbacterial complex. PET scan revealed a benign tumor in the abdomen. Treatment and management. Initial treatment complication. Initially, empirical antituberculosis treatment was initiated, which led to a drug-induced hepatitis and ototoxicity, which required regimen adjustment. Revised treatment strategy. Switched to non-hepatotoxic drugs and antifungal therapy for histoplasmosis to minimize complication. Targeted therapy for co-infection. As MAC and histoplasmosis were detected, they started with the clarithromycin, ethambutol, and amphotericin B drugs. Then for long-term use, they initiated intracanalizole. Consideration of surgical intervention. Persistent abdominal pain led to a discussion on surgical options and successfully done laparoscopic surgery and removed 3 the lymph node biopsy revealed MAC infection. These are some of the treatment and the complication. When the antituberculosis treatment was started, patient experienced partial ototoxicity. When intracanalizole was initiated, there was an increase in the liver enzymes and which caused jaundice. When antibiotic like clarithromycin was started, still the symptoms were not decreased. Clinical improvements. Partial symptom relief. Despite intensive treatment, the patient experienced only partial clinical gains, requiring ongoing observation. Challenges in prognosis. The interaction between the HIV-related opportunistic infections and drug side effects complicate the prediction of outcome. Need for long-term management. Customized follow-up strategies were established to enhance immune recovery and avoid relapse. Discussion. Complication of co-infections. HIV compromises the immune system, rendering patients especially vulnerable to opportunistic infections such as MAC and histoplasmosis. Challenge in the diagnosis. Similar symptoms frequently postpone accurate diagnosis, requiring comprehensive imaging, microbiological and histopathological examination. Personalized treatment strategies. Addressing multiple infections demands a balance between efficacy and toxicity, avoiding drug interaction and adapting to the patient responses. Role of multidisciplinary care. The management of specialists in infectious diseases, radiology and microbiology enhances diagnostic precision and therapeutic results. So, the key takeaway from the case are like it highlights the complexity of managing co-infections in advanced HIV and necessity of thorough diagnostic evaluation. Importance of opportunistic infection evaluation. Clinicians should maintain high index of suspicious for infections like MAC and histoplasmosis in HIV patient with persistent symptoms. Role of collaborative care. Multidisciplinary team improve diagnostic accuracy, treatment efficacy, and long-term patient outcomes in advanced HIV cases. These are my few references. Thank you.
Thank you, Mr. Chupa, for the presentation. Can we have the next presentation? Any questions? Mike. Yes.
That's very good. But a few things for your consideration in the later stage. Try to tell us whether the CD2 counts were very low and the viral load were high, and whether the patient was on antiretroviral therapy. So that is fundamental in the treatment of all of the underlying opportunistic infections. Then also has a thought process on how this patient develops two exogenous organisms, not endogenous organisms, almost at the same time, causing the pathological problem. The third part of it is, always before you go in for surgery, make a clinical diagnosis. Lymph nodes do not cause pain. I have no indication to remove a lymph node unless it is causing obstruction. So even if it is mesenteric lymphadenitis, if you had got that lymph node, what is the biopsy report, the histopathology of that lymph node is my question. Do you have a biopsy, histopathology of that lymph node? And as a surgeon, any removed structure must be biopsy, must undergo histopathology study.
So, good morning. Actually, this case was treated in Asha Hospital, Mysore, and somehow the So it was a completely messed up case. First patient was went to the biggest sanatorium of PV in Mysore, where they, with seeing the ultrasound, they started on empirical ATP. Patient developed hepatitis. Then started on streptomycin and other levofloxacin, non-hepatitis. Then they developed water toxicity. Then we were called for the making a new diet to work up. Then initially we did a urine, CD4, I think it was 20-30 something, I don't remember. We did a urine histoplasma test on that, and it was positive. So without the histoplasma, we started antifungal only. Fever was persisting. Then we asked the surgeon to do a diagnostic laparoscopy because there was a lot of lymph nodes. CT also showed. So the first the biopsy showed only reactive lymphadenopathy. So we were helpless. Again, continued same treatment. Fever going up. Then we asked another surgeon to give one more opinion, sent to a different pathologist. So we suspected some malignancy. So this was a oncopathologist. So he actually picked up the MAC in the histopathology report. Thank you.
Thank you. I think we're ready for the next presentation. Thank you, Mr. Chopra. I would like to call for the second presentation Mr. Tarun D. for the burden of sarcopenia, analysis risk factors among HIV infected patients.
Yeah. Good morning, everyone. Delegates on the day and off the dance. Speaking sarcopenia, the burden of sarcopenia. I think I need a question mark. Is this a statement? Is it really we have a burden of sarcopenia? I gave it as a statement. Let's prove it wrong or right. Yeah. From 2019 to 2022, the estimated incidence of sarcopenia is 5 million in Southern Asia by Ibrahim et al. And it is predicted to be 50 million by the end of 2050. I don't know on what basis they gave this prediction. Let's move on. Sarcopenia is a condition categorized in progressive and generalized degeneration or decreased skeletal muscle mass and thereby overpowering by our visceral fats. In sarcopenia, what happens is there are a lot of muscle mass accumulated surrounding your skeletal muscles, which impairs the physical performance, function, independence, and thereby reducing the functional dependence of the HIV patients. Thanks to our antiretrovirals, it has increased our lifespan of HIV patients, thereby having further consequences. Increasing lifespans means increase in chronic low-grade systemic immune activation, thereby increasing cellular assassinates, thereby decreasing physiological functions. So, what we know about sarcopenia, it's of two types. One is only age-related. We don't have any evidence other than that. That is primary. Secondary is based on our physical and nutritional value. Physical activity, obese, not consuming more protein, not exercising regularly, disease-related inflammatory conditions, any chronic diseases, hyperthyroidism, cardiorespiratory problems, and sarcopenia is also associated with the clinical outcomes like falls, frailty, osteoporosis, fatigue, dysphagia, and etc. etc. So, our main objective, first one is to assess the prevalence. That's a primary. So, sarcopenia can be assessed by muscle mass, muscle strength, and mobility of the muscle. So, assessing muscle mass can be through DEXA test or bioelectrical impedance. And assessing muscle strength is by hand grip strength and any medically approved handheld dynamometer. And assessing muscle mobility by gait speed. So, walking at least 6 meters in less than 5 seconds. There's some objectives. Inclusion criteria is common. I have included age above 30 years because I want to see whether the sarcopenia exists in the young population as well. Medication whether it's identified without comorbidities, exclusion pregnant population. population muscle disorder, sympathomimetic drugs. Why sympathomimetic drugs? It reduces the duration of the contraction, beta to activation, thereby reducing the peak muscle tension in patients. Thereby we avoid these patients. Methodology. First step, patient was screened for inclusion and exclusion criteria. Step 2, consent form should be taken good clinical practice, we don't ignore it. Third step, social demographic details with all the regimens, duration of EID, etc. SARC questionnaire, which assesses the muscle strength, which assesses the self-assessment of muscle strength and mobility. It is two domains, muscle strength and muscle mobility, not assessing muscle mass. Then self-reported. Why self-reported? Because patient assess themselves. It's given subjective evidence for the patient. And step 5 is maximum measured value of hand grip strength taken per ground, best of 2 was taken into account, and which maximum grip strength was taken. Step 6 is measurement of gait speed. If he doesn't walk 6 meters in less than 5 seconds, he was classified to gait, low gait speed. So these are the SARC questionnaire, which tests the muscle strength and muscle mobility according to their own patient. And SARC questionnaire, if we have 3 options, 0, 1, 2, each question have 0, 1, 2 options, and SARC questionnaire more than 4 predicts the more predicts the sarcopenia, which needs comprehensive care and attention. And this one, very important, criteria for sarcopenia according to BMI. So, hand grip strength can be measured with a medically approved handheld dynamometer. Why did I choose this criteria? BMI according to various, this is not the usual classification of BMI, right? Usual classification is an 18 to 19 to 25, 25 to 25, more than that. But this is very validated criteria by Friday et al. This tells that Friday et al. Did a very good metabolism, fat metabolism, metabolic changes in various BMI population, and further he classified less than 24 to 26, which in turn which gives substantial evidence for hidden obesity. What is hidden obesity? Hidden obesity is when the patient is in proper BMI range but increased fat content in his body. So coming to results, we have recruited 270 patients, and then 167 were male, 103 patients were female. From there, 79 patients were in male population. 79 patients have low hand grip strength. In female, 67 people have low hand grip strength, which gives us a prevalence percent of 54%. So, what algorithm I followed is patient assessing hand grip strength, and from that, low or high. In that low patients, we'll test gait speed. In gait speed, who have low gait speed will be classified as sarcopenia. So this is the various BMI ranges. In this you see 26 to 28 BMI, we have so much of sarcopenia in male, and in more than 29 BMI, we have more sarcopenia in female. Yeah, speeding up. And doesn't stop it. And yeah, this is not statistics, these are all numbers. But what we see in less than 24 in male and female, there are a lot of sarcopenic patients. I mean, low hand grip strength patients. Is this a hidden obesity where the BMI is in proper range but the fat content might be more? That's my biggest limitation. I'm very sorry I couldn't know it, because its muscle mass is assessed by DEXA test. It's a gold standard method for assessing fat content, visceral fat, visceral fat, subacute fat, as well as lean body mass, and biological impedance, BRA. So SARC questionnaire. In this we can see strength assistance in walking. So much people completed more than attained sarcopenia. We can see assistance in walking, rising chair, climbing and walking, people need so much. And Sarcopenia, according to Hand-Gibson of 131, further stratified, it came to 50. Sarc questionnaire more than score more than 4. Female have more population. Why? No, female complains more. Sorry. Sarcopenia using Hand-Gibson and further classified into game speed. From 141, it went to less than 50. In total of 270 patients, we had 141 Sarcopenia HGS, low HGS, and it was further stratified into 50, where male had 1.33% more risk than females.
Tarun, please conclude.
Yeah.
That's last.
Yeah. And these are the predisposing factors.
Last slide, please.
Yeah. So there are various predisposing factors like CD4 cells, less than 200, alcoholism, smoking, and I did not mention about ART regimens. ART regimens, we had two types. One is TLD and one is with dolutegravir, one is with atazanavir and ritonavir. In dolutegravir patient, what happens is, it reduces the adiponectin levels. Adiponectin functions are increased fatty acid oxidation, reduces the glucose production in liver, improves insulin sensitivity. So thereby, the focus group should be our CD4 less than 200 cells and alcoholism and yeah, smoking and rural area patients mostly. And our take-home message for this aerobic exercises and resistance exercises, which improves this sarcopenia condition by 5 times, which was given by Ibrahim et al. In a systemic study. So most effective intervention can be exercises. WHO guidelines do not give any proper exercises for thing. We have to develop further, and yeah, that's it.
Thank you. Thank you, Tarun. I think we have taken more time, so we will go for the next session, next lecture by Dr. B. Akhila Reddy, triglyceride glucose index and its association with metabolic syndrome in PLHIV on stable ART and analytical cross-sectional study.
Good morning. This is B. Akhila Reddy. I'm a postgraduate student at Kasturba Medical College, Mangalore. Today I'm going to present my research on triglyceride glucose index and its association with metabolic syndrome in people living with HIV on stable antiretroviral treatment. It's an analytical cross-sectional study. HIV remains a major global health challenge with millions affected, and with antiretroviral therapy has improved survival rate, it has also contributed to rising burden of non-communicable disease, including metabolic syndrome. Metabolic syndrome in people living with HIV is driven by chronic inflammation, mitochondrial dysfunction, and ART-related metabolic adverse effects, thus increasing the risk of type 2 diabetes and cardiovascular diseases. The triglyceride glucose index assesses insulin resistance using fasting blood glucose levels and triglyceride levels. The triglyceride glucose index is calculated with the help of fasting triglycerides into fasting plasma glucose divided by 2. The triglyceride glucose index could be a cost-effective surrogate marker of insulin resistance, potentially aiding in early detection and management of metabolic complications in people living with HIV, especially in resource-limited settings. However, further research is needed to validate the triglyceride glucose index and its utility in the population and optimize its integration in routine HIV care. The aim of the study is to evaluate the utility of triglyceride glucose index as a surrogate marker of metabolic syndrome in HIV patients on stable antiretroviral therapy. Objectives: to detect an association between triglyceride glucose index and metabolic syndrome in patients on stable ART, to detect an association between baseline HIV-related and non-HIV-related factors in patients with metabolic syndrome on stable ART, and to detect any association between triglyceride glucose index and cardiovascular risk score. Materials and method. This is a cross-sectional study which was conducted at a tertiary care ART center of KMC Mangalore from April 2023 to November 2024 after approval of Institutional Ethics Committee. After obtaining a written informed consent, 142 HIV patients were recruited through a non-randomized surveillance sampling. Metabolic syndrome is defined using the International Diabetic Federation criteria. Data collection involved information related to clinical evaluation, anthropometric measurements and laboratory tests including fasting plasma glucose and triglyceride levels for calculating the triglyceride index and the cardiovascular risk score. Patient selection includes the HIV positive patients who were on stable ART for a minimum of 2 years, age greater than 18 years to 60 years, and after the consent. Exclusion criteria include poor adherence to ART therapy, on treatment for dyslipidemia, diabetes, and on treatment for diabetes, cardiovascular disease and on treatment for it, chronic illness such as chronic kidney disease, chronic liver disease, and malignancies, endocrine conditions like thyroid and adrenal illness. Out of 142 HIV patients, 33 patients were found to have metabolic syndrome, and 109 with no metabolic syndrome. And metabolic syndrome was defined as per International Diabetic Federation criteria. Out of various variables were taken into consideration, which include demographic data, which included age, gender, and economic status, which showed no significant association in patients with metabolic syndrome and non-metabolic syndrome. Among the non-HIV related factors, which included family history of diabetes, family history of IHT, smoking, and alcohol abuse, there was no significant association with metabolic syndrome or no metabolic syndrome. Likewise, in HIV-related factors which included ART regimen, recent viral load, duration of HIV, duration of ART, and recent CD4 count, there was no significant association with metabolic syndrome or no metabolic syndrome. However, there was a significant association with triglyceride index with metabolic syndrome with a p-value of less than 0.001, and also there was a significant association with cardiovascular disease risk and metabolic syndrome with a p-value of 0.005. There was a positive correlation between the triglyceride glucose index and a cardiovascular risk score with a p-value of less than 0.001. I would like to summarize by saying that there is no significant association observed among HIV-related and non-HIV-related patient factors in patients with metabolic syndrome and non-metabolic syndrome. Those with metabolic syndrome were HIV positive and on treatment for a longer duration with a good immune response to ART. A positive correlation is observed between a triglyceride glucose index and a metabolic syndrome as per the IDF definition with a p-value of less than 0.001. A positive correlation is observed between the triglyceride glucose index and the calculated cardiovascular disease risk score with a p-value of less than 0.005. Conclusion: the triglyceride glucose index has a positive correlation with the calculated atherosclerotic cardiovascular disease risk score. The triglyceride glucose index can be used as an alternative marker to assess the cardiovascular disease risk in HIV population with stable ART. These are my references. Thank you.
Thank you, Dr. Reddy. Do we have any questions on this?
Very, very well designed study. It's for your PG thesis. Very good. Just a second, you were saying that there is a positive correlation. Good. That's for your summary of your finding. But the atherosclerotic risk factor analysis doesn't require any investigations other than HDL level and cholesterol level. The rest is age, smoking, the presence or absence of diabetes, and other factors. So, are you saying that this is only for, what is the meaning of this positive correlation? In other words, can we do away with the other testing, or should we act on this abnormality In what way should we act? We're finding positive correlation is good with the atherosclerotic risk. What is your message after that? I will stop smoking. I will control my weight. I will control my diabetes. I will control my triglyceride levels. Is there any additional thing that we have to do to bring down or modify this risk factor which you are now suggesting?
So my study is basically the triglyceride index. So the traditional method to calculate the insulin that's distinguished by HOMO-IR, which is the calculating insulin level. So it's simple tests such as the triglyceride index will help to calculate insulin resistance resource limited category. So this triglyceride index has a risk. It helps in assessing the metabolic complications also.
Because in non-HIV infected, you don't worry too much about triglycerides unless it is more than 500. 250 is okay unless more than 500. I don't know what is the number you want for HIV, where we should act upon.
According to the ideal triglyceride levels more than 1.
Thank you. Thank you very much. Thank you for the speakers who have spoken.
Thank you very much. I would request Dr. Lenacapavir to kindly hand over a token of to Dr. Uday Jadhav. Dr. Bandhai. Thank you. With that, we move on to our next session, which is HIV epidemiology. Where are we today? To chair this session, I would like to call upon Dr. Kartik Shah and Dr. Dilip Bandhai.
Is the UNAIDS Country Director for India. He is a development ticket.
Thank you very much. Dear, once again, a very good morning. And the topic is related with so let's go once again to basics of HIV. And there are three speakers with me. Dr. David Bridger is with me. Dr. Uday Bhanu sir, I already met him sir. And Dr. Venkatesan Chakrapani is with us. As you all know that this virus was detected by French, in beginning it was detected by French scientists. And it was named as LAV, lymphadenopathy associated virus. And later on by USA, it was named as HTLV3, human T cell lymphotrophic virus 3. And later on in May 1986, it was termed as HIV by International Committee on Bacteriology. So now I would like to request Dr. David Bridger to come on the stage and deliver the lecture on ending AIDS in Asia Pacific pathway. Dr. David sir, please.
ASICON welcomes Mr. David Bridger. Mr. Bridger is the UNAIDS Country Director for India. He is a development economist with over 25 years of experience in international development and has worked for the United Nations for over 20 years. Dr. Bridger has served as the UN Resident Coordinator in Armenia and as the resident representative of the United Nations Development Programme, UNDP, in Armenia. hear him talk about ending AIDS in Asia Pacific, the pathway ahead.
This is an online talk. He'll be presenting it online in the session.
Greetings, everybody. My name is David Bridger, and I'm the Country Director of UNAIDS here in India. Firstly, my apologies that I can't be with you physically today, and apologies that I have to do a taped presentation, but let me just take you through what I hope is something that will be of interest. I think globally, regionally, and here in India, we do have a choice. There is a choice. We can act now to end AIDS as a public health threat by 2030. We can actively work to keep people living with HIV on treatment and healthy. We can accelerate efforts to reduce new infections substantially, and we can almost eradicate AIDS-related deaths. But to do so will require firmer commitment by leaders to invest in effective programs that engage the community, further reduce stigma and discrimination, and address sustainability and integration of the response. There is a pathway to ending AIDS, and we have a map. Are we bold enough to follow it and accelerate our progress? The data being used in the presentation is actually drawn from two global sources, two global publications that are available on our internet page. First of all is the 2024 Global AIDS Update, published in July 24, entitled The Urgency of Now, AIDS at a Crossroads. This publication looks at where countries are in relation to all of the 2025 global targets, and it looks at those countries in respect to their 2023 data. The second publication is the 2024 World AIDS Day report, published in December 24, Taking the Rights Path. And this publication looks at the enabling environment, reminding us of the critical need to address laws and policies as we move forward. So you can see here that some Asia-Pacific countries are on track to achieve the Global AIDS Strategy 2025 targets. Yes, those targets are ambitious, but they are indeed possible. And in fact, 9 countries globally have already proven that. And we can see here that there are 4 countries in the Asia-Pacific region that are also on track to reach those treatment coverage targets, namely Cambodia, Nepal, New Zealand, and Thailand. Prevention is another story. Prevention efforts are not as powerfully being upheld, and we can only see at the moment Nepal on course to reach the target of 90% decline in new infections by 2030. When we look at India, we can see that there's also a clear path to the 2030 goal of ending AIDS, but the trajectory may not be fast enough in order to meet those goals. So annual new infections have significantly declined by 44% from 2010 to 23, but still a fifth of the estimated people living with HIV do not know their status and are not on treatment. We need far more acceleration of HIV prevention efforts here in India, whereas in annual AIDS-related deaths, we've seen a very promising decline of 79% decline from 2010 to 2023. Here, the treatment benefit is clear. One of the key approaches of the Global AIDS Strategy is U equals U. Yet this concept, this reality of treatment as prevention, is poorly leveraged and applied throughout the region and especially here in India. Of course, U equals U is undetectable equals untransmittable. And I know all of you understand this concept, but just for the sake of us, it means that a person living with HIV, if adhering to effective HIV treatment, achieves an undetectable level of virus in their blood, then they represent zero risk of transmission of HIV to others. This is really a huge game changer, one which we have not utilised and talked nearly enough about throughout the region and here in India. There are several benefits, and reducing stigma is probably the key. HIV no longer equals death. I think we really get that message out more clearly and more broadly. The diagram above highlights the potential that prevention gains are clear, and we need to be talking about this far more across the health sector, but also publicly. If we look at the HIV testing and treatment cascade for the region, we can see where, despite substantial progress, we still have a critical gap. In the region, 78% of people living with HIV know the status, but nearly a quarter do not. And as I said before, in India, this is around 81%, and nearly 1/5 do not know this status. 67% regionally that know their HIV status are on treatment. In India, that's 71%, and 65% of those on treatment are virally suppressed. And near to that in India is 69%. The alarming point here is that in the Asia Pacific region, nearly a third of people living with HIV are not getting the care and support they need to stay healthy and prevent transmission. The data for India on this slide shows a progressive and steady improvement over the past 5 years. But really, we still need to see a strong push in order to reach those global targets. The testing and treatment cascade in India was around 58, 56, 40 in 2018, and it's now sitting at 81, 71, 69 in 2024. Asia Pacific has the second largest epidemic globally. For the world to end AIDS, we must get it right here in Asia and the Pacific, but also in India, because India has the second largest number of people living with HIV outside of South Africa. 1.6 million people in India living with HIV, and 6.7 million people living with HIV in the Asia Pacific region. Both the AP region and India are central to the global response. As we can see here, Asia Pacific accounts for a quarter of the new infections in the world. Globally, 1.3 million new infections last year, and in the Asia Pacific region, 300,000 new infections. These graphs show the decline in new infections from 2010, and we can see that the global average over this period is a 39% decline, for the Asia Pacific region only achieving a 13% decline. We see in this next slide, India has achieved a solid 44% decline, but we still have a way to go in achieving the 90% target. The sheer number shows how critical it will be for India to make this goal. It can help carry the Asia Pacific region ahead. India accounts for 5 to 6% of global new infections and 23% of new HIV infections in the AP region alone. Perhaps the percentages don't drive the reality home enough. And so let's look at impact in terms of people's lives. Every 2 minutes in this region, one person is newly infected with HIV. Every hour, this represents 35 people newly infected, including 9 young people. Every day, 300 men who have sex with men, 80 people who inject drugs, 50 sex workers, and 15 transgender people become newly infected. Every hour, 17 people die of an AIDS-related illness, and every day we lose 9 young people between the ages of 15 to 24. Let's have a quick look at what's happening on a country-by-country basis since 2010, where you can see some marked differences between countries. The graph at the top shows the percentage change in new infections by country since 2010, and you can see that there are growing epidemics in 6 countries: Bangladesh, Laos, Papua New Guinea, Afghanistan, Fiji, and the Philippines. When we look at the mortality trends in the lower graph, we see all of these 6 countries have increasing death rates, as well as Pakistan, Indonesia, and Mongolia. HIV is concentrated among key populations and their partners. In In 2022 in the Asia Pacific region, 4 out of every 5 new infections were among key populations in their sexual partners. This translates to nearly 80% of new infections were among key populations and their sexual partners. Of this, 43% were through male to male sex. This is an increase of over 34% over the past 10 years. These epidemics are becoming more interconnected, and countries are seeing different dynamics emerge. Just to give a couple of examples, the Philippines has one of the fastest growing epidemics today. A near 500 to 600% increase, an epidemic largely driven by male to male sex and predominantly young men who have sex with men. Fiji is another example where we're seeing a dramatic 200+% increase, largely driven by intravenous drug use. The key element to these dynamics in Asia Pacific and India is related to young people. As the bottom graph shows, around a third of new infections in the region are with young people, with a number of countries seeing these rates close to or above 50%. India, not on the graph, is around 20 to 25%. The top left graph shows how dramatic these increases are for several countries. The top right graph shows how serious this is for young MSM across the region, where we have seen prevalence among young MSM double in the past 7 to 10 years. We really need to scale up innovative interventions and differentiate HIV services across the prevention and care cascade. Access to combination HIV prevention services among key populations throughout the region remains limited. Coverage is on an average near 47% for female sex workers, 31% for men who have sex with men, and 34% for transgender people, and only 21% for people who inject drugs. Pre-exposure prophylaxis, or PrEP, has been available for many years, and we've had this tool available in the region, but uptake is low. India is yet to adopt and utilise. You can see from the slide here that currently in 2023, only 204,000 people are using PrEP in the region. This is well short of the regional target for 2025 of 8.2 million people. We know PrEP works. We need to take it to scale for those who need it most. We really do need to offer a range of prevention measures for all. More recently, we also have heard the great promise of long-acting injectables and the prospect of the price declines that may make them more accessible going forward. When we look at treatment coverage, we can see the unequal performances, with some countries not even reaching half of the estimated people living with HIV. Most Asia Pacific countries are in the middle, like India, but they also need to increase their pace. If we are to realise the impact treatment can have, every gap in this treatment cascade represents potential lives lost and further increases of new infections. So why do some people fail to come forward and get tested, and why do some get tested then fade back into the shadows? This brings us to the social and structural barriers that drive people away from HIV services. There are legal barriers to the response across the region. You can see the extent of this here and the number of countries that still criminalise certain behaviours. Progress is slow, and we see few changes every year. For key populations in countries, these are the reasons to remain fearful and at arm's length of life-saving services. And you can see this slide, how this manifests into stigma and discrimination across the region. I won't take you through each of the examples, but you can really see how important you equals you is to explode the myths that HIV does not equal death. Over the past 10 years, external funding has decreased by 60%. And in the last 3 weeks, that figure has potentially increased even further. While domestic resources have increased by a significant 47%, funding around 95% of its national response. 12 of the 17 countries we analysed rely on international sources for more than 50% of their HIV prevention financing. This is a serious sustainability issue. This graph shows that 9 of the countries are spending less than 15% on key population-focused programs. There is clear guidance on how we should invest those resources more effectively. The Global AIDS Strategy calls on countries to ensure that 30% of testing and treatment services should be delivered by community-led organisations. 80% of service for delivery for HIV prevention programs for key populations to be delivered by community-led organisations, and 60% of programs needed to support the achievement of societal enablers should be delivered by community-led organisations. Often a more cost-effective and impactful way to reach key populations. So the game changes, the pathway forward. We have a set of regional priorities and country priorities here in India that we feel will end inequalities and end AIDS as we move towards those 2025 targets. Let me take you through those 4 very quickly and just highlight a couple of them. First of all, renewing and intensifying focus on key populations. We really do need to refocus and ensure that we are targeting the right populations, the right interventions, in the right places, and we are doing this at scale that will have impact. Secondly, we need to modernise service. This means adopting innovations, using prevention tools to their fullest. This includes PrEP, long-term injectables and self-testing. We need to be planning for the introduction of long-term injectables, and we need to be doing that planning now. Thirdly, eliminating barriers to equitable program coverage. So this is really addressing the enabling environment, looking at those legal and structural barriers that are fueling and continue to fuel stigma and discrimination. And fourth, mobilising sustainable policy, program and financing for HIV response. So really investing more in prevention and community-led programming, looking at integration and sustainability. These are key now. Countries need to look ahead and build scenarios for populations living with HIV as they age. We also need to support the integration of HIV back into the main health system without it losing some of its unique features and advantages. And finally, just a quick thanks to you and apologies that this was rather a rapid tour around the region. We will be reaching out to you in the coming months as we pivot in these difficult times to build momentum for the development of the next Global AIDS Strategy for 2026 to 2031. This will be a challenging task, and we will really need your ideas and your support to ensure we preserve the gains made in the HIV response today. Thanks again.
Thank you, Dr. Bridger. Wonderful presentation. Sitting at the top of 52 nations, handling around 6.5 million patients, you have a good bird's-eye view of the entire situation in the Asia-Pacific region. And you have assigned or you have designed several strategies to help combat it. I'm a treating physician, seeing a patient eyeball to eyeball, but I am not able to retain patients under my care. I wonder what is happening in all of these countries, and I'm also wondering how you're capturing them. Are they just lost to follow-up, or they are just dying out there? I have no data on that, but country data says that about 1.7 lakh, 170,000 people are lost to follow-up, which is 5% of the patients. Are we using any methodology to trace them out, sending the Army, Navy and the Air Force to see that they come back to treatment?
Thank you very much, Dr. David Bridger, sir. Thank you very much for stressing on U is equal to U, and also stressing on our target of 95, 95, 95. And also you told us about it is possible to end the epidemic as we are having 68,000 annual HIV cases.
Dr.
And if we
Vijay
talk
actually
about
just
2671.
Dr. Vijay just logged off.
Okay, sir. Okay. So we will go to next speaker, Dr. Uday Bhanu Das, sir. Please, sir, deliver your lecture. Sir, thank you.
Dr. Uday Bhanu Das. Dr. U.V. Das is a distinguished officer of the Central Health Services Cadre, Ministry of Health and Family Welfare, Government of India. Currently serving at the National AIDS Control Organization, NACO, he oversees critical divisions related to laboratory services, diagnostics, and program management. He is experienced in emergency medical response with the Directorate General of Health Services and has contributed to the management of public health emergencies like the Nipah virus outbreak, Zika virus outbreak, and COVID-19. We look forward in hear him talk on national response to HIV epidemic in India, current scenario.
Okay, good morning to all of you. So I can see many research faculties, eminent academicians, researchers, the government sector, the private sector, as well as my colleague Dr. Karthik Shah from the Gujarat State AIDS Control Society. So, Government of India we maintain our own stand. First of all, let me make it very clear. Regarding the funding part, presently the National AIDS and STD Control Program is 94% funded by Government of India, and we take only 6% of the fund from Global Fund. That is $500 million over a period of 3 years. And India also contributes $95 million every year, every grant cycle, to the Global Fund. We also, Government of India also contributes to WHO when the funding rounds, to Gavi. So we have an equal stake in the health affairs at the international level. And we are no longer dependent on foreign aid or foreign funding. First of all, let me make it very clear. Secondly, I will come to many other aspects at the policy level. I won't speak. I am from a community medicine background. Basically, I am not a researcher or a clinician. And so at the policy level and the stand of the government, the perspective of the Ministry of Health, Government of India. And I will request UNAIDS and WHO to publish the data of China. They never show the data of China. China is at the population, we just surpassed China last July. I think UNFPA published the population data where we crossed 1.4 billion and we surpassed. But why is China's data never published by UNAIDS or WHO? This is my query and also my request to UNAIDS and WHO. So they should also show the data of China when they show the data of India, so that we can compare apple to apple. You cannot compare apple to orange, you cannot compare India with Philippines and Vietnam and Cambodia. That's very unfair comparison, first of all. Now coming to the program where I am working. Next slide, please. So as Dr. Karthik already mentioned, so Ministry of Health and Family Welfare constituted a committee in 1986 by the Honorable Prime Minister, and we launched the National AIDS, and it is a central sector scheme. That means 100% funding comes from Government of India, including the medicines, the diagnostics, the salary of the staff. We pay for everything. Giving a perspective of the comparison where India stands with the global, compared to the global data. So the estimated people living with HIV, because you know that this is a kind of, there is a lot of stigma attached and it's impossible to do a head count. In tuberculosis you can do a head count, it is a notifiable disease. But in HIV/AIDS it is very difficult to keep a head count, and given the stringent laws of the HIV Prevention and Control Act, which was passed by the Parliament of India in 2017, where the HIV positive or HIV infected person has a right to disclose or not disclose. We cannot force that individual to disclose his HIV positive data. So that's a hindrance. So we do an indirect head count, that is an estimate. So as compared to the global average, we have an estimated 25.44 lakhs. The 2024 estimates are yet to be published, so there might be a slight variation. And the new infections, the estimated new infections, it is 68, maybe 70 to 75,000. These are approximate figures. And the PLHIV, that is the persons living with HIV on antiretroviral treatment, we provide free lifelong antiretroviral treatment under the program to an estimated population of 18.006. And the AIDS-related death means may not be directly due to AIDS, may be due to tuberculosis or other morbidities. It is estimated to be maybe 37, 38,000. It is an approximate figure. And as I told you, the population figures, the adult HIV prevalence is 0.20, but the population, the key population wise, the numbers are different. I will come to that later on. Decline has been, even Dr. David Bridger pointed out that in the last 13 years, there has been a decline of 44.20. And the total AIDS-related deaths has been 35,900. And in percentage terms, we have achieved an approximately 80% decline in the deaths. The current status is that the achievement so far, during the current financial year, that is 24 to 25, is the first 95, that is the estimated number of people living in our country who are aware of their HIV status, means they are tested for HIV and they know their status is 84. This may be differ by 1 to 2% as on today's date when we are meeting here. The PLHIV of the persons living with HIV who are on antiretroviral therapy is out of that 86% are on antiretroviral therapy. The target is to reach 95, and those who are virally suppressed means the viral load count is less than 1,000 copies per ml, that is 94%. So the national prevalence means if we take the prevalence rate of all the states and then take out an average, that is 0.20. But there are certain states, especially if you see to the right side, Mizoram, Nagaland, Manipur, the northeastern states, and the traditionally high burden states of Andhra Pradesh, Telangana, Meghalaya. There the prevalence rates are much higher as compared to those like Jammu Kashmir or Jharkhand or Kerala. Even here, I will be very frank to say that maybe these states, the states where we say that the prevalence rates are down, for example, UP, Himachal, Odisha, there the estimates might not be accurate, because some of you who are from the statistics background or who go for field level surveys, you will agree that these estimates are based on the denominator, the number of people you are able to track and test, the figures will vary. So maybe it is just like a census figure that you calculate the number of people who are above the poverty line and below the poverty line. So in those states where the data collection or the data validation is not up to the mark, there the numbers will be low. And the states which have a traditionally robust system to collect the data and then to analyze the data, there the prevalence rates are higher. So having said that, as on date, the prevalence rates are higher in Meghalaya, Telangana, Andhra Pradesh, Manipur, Mizoram, and it also depends on the socio-economical behavior, the cultural patterns. Because if you go to if any of you have visited the northeastern states, the cultural practices, the traditional practices over there, because they have predominantly tribal population, there the cultural practices are different compared to the mainland states, for example, Gujarat, Maharashtra, UP. So we cannot, even that comparison will be unfair if we cannot say that one size fits all, given the diverse demographic and social pattern we have in the country. However, the trend is that we are seeing an upsurge in the prevalence rates in Arunachal, Assam, Meghalaya, and these are primarily due to IDUs, the easy availability of drugs and the injectable drug users, especially among the young population. The IDU use is driving the epidemic in these countries. these states. Sorry. So among the key population groups which we call the prison inmates and the female sex workers and the men having sex with men, the people using the intravenous drug use, the transgender population, men having sex with men, and then the long distance truckers. We call it migrant population, truckers and the migrant population, because there is a high mobility from the to the urban areas. For example, in Ahmedabad, you will find people who are from Bihar or UP working as casual laborers in the metropolitan clusters like Ahmedabad, Mumbai, Bengaluru, etc. So there the prevalence rate will be higher among those kind of population groups. And if we see district-wise how the prevalence has increased, so traditionally when the epidemic in our country started, the HIV epidemic, it was concentrated in the southern and the western states of Tamil Nadu, Andhra Pradesh, Maharashtra, and gradually it has spread as there is a floating population and due to migration, inbound and outbound migration. The epidemic is now spreading to other areas, for example, Rajasthan and Haryana and Himachal and Uttar Pradesh, Bihar and the northeastern states. So that is a cause of concern. So I did not go into the program-wise phase. Now currently we are in the 5th phase of the program, and we are planning for the 6th phase, the 6th funding round. Dr. Sachdeva is my senior from the NACO. He was earlier in NACO and he was also the Deputy Director General of PP. So he can elaborate that now every government program has to apply for the funding for the next 5 years in line with the Finance Commission. So today we are having a meeting in Delhi for the funding cycle from 2026 to 2031. So we will then apply to the Finance Ministry to receive the funding for the next 5 years. So as it has already been highlighted, that the end objective is to end the HIV/AIDS epidemic as a public health threat by 2030, that is in line with the UN SDG goal 3.3. So the unique features of this, because unlike tuberculosis or unlike any disease, the challenge in this disease and for this program is that once you detect somebody, you have to maintain that person on treatment and ensure that that individual is virally suppressed, so that that individual is not able to transmit the disease to anyone else in the society or in his family or close contacts. So that is the challenge, unlike tuberculosis or any other disease. So we emphasize, then we implement it through the state AIDS control societies. So we give the funds and we also provide the guidelines and the protocols to the state AIDS control society, and they implement it further down at the district level and the local level. And we have a TRG, the technical resource group, where we have faculties from all over the country, even the international experts. We have faculty from all the eminent institutes of the country, for example, AIMS New Delhi or NIMANS Bangalore or CMC Vellore. Or there is no distinction. We don't distinguish that we will not take from the private sector or only from the government sector. It's not like that. Eminent professionals and eminent researchers, faculties are taken as members of the technical resource group. And we also ensure community engagement, because the traditional government machineries will not be able to reach the grassroots level. For example, if I tell a government functionary to go to a slum and distribute condoms, he or she may hesitate, or the delivery will not be as efficient. So we involve and we employ local NGOs and to do the last mile service delivery at the local level and at the rural level. So the guiding principles are to keep the beneficiary and community at the center, leveraging technologies and innovation as the critical enablers, breaking the silos. We now presently every month we are conducting under the National AIDS Control Program 1.4 lakh viral load tests. We are conducting every month 2,000 early infant diagnosis tests, where the first, as you are all aware, that the first test is done at 6 months, then 6 weeks, then 6 months, then 12 months, then 18 months, and those who continue breastfeeding for even beyond 18 months, those especially from the lower socioeconomic background. So they prefer to continue breastfeeding for a longer. So the last test is done at the end of 3 months after the breastfeeding. So at 6 weeks we do the total nucleic acid test for the infant, and then at 6 months, 12 months we do the antibody test. And then we follow a 3-test algorithm to ensure that the baby is HIV negative, and to ensure, and if any baby is found to be positive, we start the lopinavir and nevirapine treatment for suppression. We then build synergies with other programs, because it is, all of you are aware that an HIV positive person with low immunity will develop, invariably develop tuberculosis, or he or she may be also having hepatitis B and other comorbidities. So we make sure that we work in synergy with the National TB Elimination Program, the National Viral Hepatitis Control Program. Because one program and one vertical in the central government or the state government cannot take the onus of treating all the diseases. So we ensure that the data sharing is taken place. Now we are working on Aadhaar ID integration, so that unique ID is created, that if I am HIV positive, then my ID can be accessed by the TB program officer also at the state and the district level, and the viral hepatitis program also. So once the doctor or the nurse at the TB center also logs in and sees, then he or she will be able to see what treatment I have been taking since my first diagnosis. And we also enhance partnership. We look forward for technical collaboration with WHO first, with CDC and other international agencies. And we augment strategic information. So all the data is now online. We are asked all the faculties, the ART centers, at the district level, at the local level, the integrated counseling and testing centers to enter it online for information management system, so that we can monitor it centrally as well at the state and the district level. Then genders, because gender sensitivity is very important, so that there is no discrimination. So if you go through the HIV/AIDS Prevention Control Act, I do not know how many of you have gone through the bylaws of this act. It clearly mentions that there has to be a system for grievance redressal at the state level. The state government has to appoint an ombudsman, and at the district level, the district complaints officer, and every private and government organization, formal organizations, has to have a complaints officer for effective grievance redressal. And that act ensures that no HIV positive person can be denied right to education, right to employment, and right to inheritance of parental property, so that there is no discrimination at the family level, at the community level, and by any organization. And there is an effective grievance redressal system for that. And prioritize and optimize the high impact program management, continue fostering technical arrangements and institutions. For us, if I talk about, because I can give you a glimpse of the diagnostic part of it. So the ICMR NARI, it was earlier called National AIDS Research Institute. Now the name has been changed to National Institute of Translational Virology and Research. That is the apex institute for the program, to conduct research and to conduct the pilot studies and surveillance. And we have we have a network of labs across the country, where we have 13 national level labs, then we have 117 state level labs. And for the treatment aspect, we have a center of excellence at 8 centers, then we have pediatric center of excellence, all in the eminent medical institutions across the country, where the guidelines are reviewed, where the treatment regimens are reviewed, where we undertake research also, and then we incorporate the findings of the research into the national policy. So it is not totally, it's not like a Sarkari type of mindset. We do not follow that mindset. Dr. Sachdeva, I will request him to elaborate more on that. So we are very open to the latest scientific developments going around the world, and we try to incorporate that, provided it is economically feasible and validated and replicable at the local level. We do not want any technology which is resource heavy, and we bring in that technology, and then we are not able to replicate at the state level or the district level. So there is no point in doing that. And so I will not go into the details, prevention, testing, treatment, and elimination of mother-to-child transmission. Here, currently the mother-to-child transmission rate of HIV is 11.75% nationally. We are trying to bring it down to 5% so that then we can apply to WHO to receive the certification that yes, India has been able to eliminate the vertical transmission of HIV and syphilis. So that is one of the priorities. And stigma discrimination I already mentioned, and also to strengthen the STI, the sexually transmitted infection, and RTA transmitted, because any HIV positive person or a person indulging in high risky sexual behavior is also prone to develop gonorrhea and chlamydia, trachomatis, mycoplasma, genitalium, etc. So we also want to take part of that, the STI part of the diseases. And prevention, I already mentioned, targeted intervention for the vulnerable populations. We have a robust IEC, that is the Information Education Monitoring. Then we have the testing network, and treatment. To treat all policy was introduced by the government in 2017, and we ensure that all those who are HIV detected to be HIV positive are put on lifelong free antiretroviral treatment, and also they undergo viral load testing as per the guidelines, and to have universal quality testing for HIV. So I won't go into the numbers of this. These numbers keep changing. The latest numbers are under validation, so this will change. So alive on ART, approximately it is 18 lakh now under the program. Annually, the number of PLHIV initiated on ART is 1.65. So this is U equal to U. The clinicians can elaborate on it further. Regarding PrEP and self-testing, these are the two things that the WHO and other. See, what is PrEP? Let me explain to you in simple terms. PrEP means you tell that person to take that medication for a period of 15 days or 30 days, and then he or she is not required to use condoms and indulge in sexual behavior with he or she may have sexual contact with n number of people. So those kind of things, they have been piloted in Africa, but it has been of no use. You can all go into the data and you can find the data that those countries where PrEP was introduced, where PrEP is basically that you do not have to use condoms and you do not require to practice safe sexual behavior, and you can have n number of partners. PrEP has been a failure in African countries, let me tell you that. Please go into the data, don't believe me. Maybe I am from the government side, so I will tell you a biased view, but please go into the data. PrEP has been a failure in the African countries. The HIV infection rate has been rising in the African countries despite the introduction of PrEP. So we do not agree with the UNAIDS or WHO on that point. And for self-testing, HIV self-testing, it is just like the COVID. If you can all recall the HIV, the COVID pandemic, at that time there were many self-diagnostic kits of COVID that were launched in the market, so that I test for and I say that I am positive for COVID and I get admitted. It will open a floodgate. We do not want that. We want, Government of India wants that we should have a calibrated and gradual evaluation of all these strategies internally. After that, we will introduce these in the program. So, because imagine the number, the population, 140 crore. So, it is very difficult, and there is no self-regulation. Even today, I can walk into any chemist shop and I can get the medication over counter. Any medication, you name it. I can get it in Delhi, I can get it in Ahmedabad, Mumbai, Pune, any city you can. So it will open a floodgate and it will be difficult to control it. So we have a guarded response to it. We are not saying no. Regarding the injectable long-term acting drugs, we are evaluating it, we will evaluate it. The challenge coming is at the last mile at the ART center in the far-flung areas, to train the nurses, to train the medical officers to use that long-acting the injectable drugs. We are evaluating it, we will be gradually introducing it. At one point of time, it was unimaginable. Dr. Sachdeva sir was there at NACO at that point of time. So it was a challenge and it was being debated that how do we introduce the antiretroviral drugs to ensure the medication reaches every HIV infected person. But finally we were able to, we were able to do it. So we will be introducing the injectable long-term antiretroviral drugs in the due course. Thank you.
Thank you very much, Dr. Uday Bhanudas, sir, DDG PMR NACO. You have explained us about NACP, and in NACP also AIDS itself is an STD. And now there is focus also on STD, sexually transmitted disease. And out of that, syphilis, gonorrhea, or syphilis is more targeted as per our program. And thank you for giving us the knowledge that we are also going towards NACP 6 and all the plannings are going on there. All the participants are requested to have questions related with sir in the note. After next speaker, we can ask him. Thank you very much, sir. Now I would like to ask Dr. Venkatesan Chakrabarti.
ASICON welcomes Dr. Venkatesan Chakrabarti. Dr. Chakrabarti is a chairperson at C#, Chennai. Dr. Chakrabarti, a distinguished public health professional and researcher with over 2 decades of experience focusing on the health and well-being of marginalized communities, particularly sexual and gender minorities and people living with HIV. He chairs the Indian National AIDS Control Organization's Technical Resource Group, TRG, on transgender people and is a member of the TRG on men who have sex with men. He is an adjunct professor at the National Institute of Advanced Studies and recipient of the Samudram Award from Samudra. We look forward in hearing him talk on navigating HIV prevention and care among key populations in India.
Good morning everyone, and thanks for having me here. So I will focus on, I will just provide an overview about HIV prevention and care among key populations in India. So mainly also talking about the key challenges and the opportunities. So mainly because my focus has been on conducting public health oriented research among sexual and gender minorities, mainly my focus will be on MSM and trans people in my talk. Yeah, so this is a simple outline. So I will first talk about who are these key populations, and then I will focus on the HIV prevention aspects and HIV treatment aspects among key populations, and if time permits, a little bit on STA as well. So according to NACO, these are the main 4 key populations, men who have sex with men, transgender women. So transgender women, usually NACO documents, you can see that as Hijra/transgender, female sex workers, and people who inject drugs or injecting drug users. Of course, there have been other terms that have been used, high-risk groups, but nowadays, it's not recommended to use that terminology. UNAIDS have sometimes used the term most at-risk populations. So I'll start with MSM. So the term MSM itself is a behavioral term coined by WHO in the early 1990s. For example, having an identity as a gay may not pose a risk. I may have an identity as a gay, but I may never engage in, say, unprotected anal sex. But it is the behavior which is actually making the people at risk. If somebody engages in unprotected anal sex, irrespective of the identity, then that is going to increase the HIV risk. From that aspect, this term came as a behavioral term. So in India, there are several terminologies have been used among MSM. So mainly we can broadly, it's a oversimplification, but I can say that, for example, people from lower socioeconomic status, they have particular identities like Koti, Panthi, and double decker. These are primarily sexual role-based identities based upon whether they engage in insertive anal sex, receptive anal sex, or both. So it's primarily we can call that as a sexual role-based identities. But there are also sexual identities, people may identify as gay and bisexual, depending upon whom I'm getting attracted to and whom I have sex with. So you may be familiar with the term LGBT. So LGBT refers to the sexual identity. lesbian women, gay men, bisexual men and women. The GB refers to sexual identity, whom I'm getting attracted to and whom I have sex with. But the T refers to the gender identity. Like it's the psychological sense of with which gender I identify myself with. So I'm born as a male and I identify as a man, so that is called as cisgender. So I'm like a cisgender man. But if I'm born as a male, but I identify as a woman, then I'm a transgender woman. If I'm born as a female, like my sex assigned at birth is female, and I identify as a man as I grow, then I'm a transgender man. So basically, but majority of, most of the time people may understand about individuals and transgender women, they are seen, but they are not very much familiar with men. There are several indigenous trans women identities in India. Of course, some people may still use the term English term transgender to refer to themselves, the transgender women. But there are also like Hijras or Kinners, which are commonly used in North India. For example, in Tamil Nadu, where I am from, they use the term like Tirulangai. So similarly, this is actually like Aryan Pasha, who is a well-known trans man. He is a professional like bodybuilder and got many several awards. So trans masculine persons are also increasingly become visible in India, and there are also many indigenous trans man identities like Tirunelveli. So now we have seen about mainly who are MSM and who are like transgender people. So coming to the HIV prevention aspects. As you can see, like again, this is from NACO's data. So you can see that HIV prevalence and incidence among key populations are several times higher than the general population. So we'll come to like why that is the case. So why there is disproportionate HIV burden among key populations. So one way to look at it is like just blame the individuals, like it is your individual behavior. You are not using condoms, you are actually like sharing needles with other people. But another way to look at it is as how the social structural forces increases the HIV vulnerability of key populations. For example, if I am a trans woman, in my family, then they will not accept me, right? So then I will run away from my home at a very early age, and I have no access to education or no other alternative like employment opportunities. So then I may engage in sex work. I join the Gujarat community, I engage in sex work, and then when I stand in the hot spot, I may be sexually abused by police or rowdy. So it is primarily because of these like social structural forces which ultimately increases the risk of the key populations. So we have to think from that public point of view as well. So NACO's projects like among key population, primarily it is through what is called as a targeted HIV interventions or TA program. Dr. Uday also talked about the TA program in his talk. So basically in the TA program, like there will be like peers. So they go and do outreach and they provide education about HIV. They also distribute condoms. They distribute like clean needles and syringes, and they also refer them to HIV testing and HIV treatment facilities. So these are the main components of the TA program. But all these are like primarily focused on like physical spaces, hotspot. But nowadays, like many people are using the virtual platforms. So whether it is like female sex workers or minimal sex women or even trans women, they have started using social media applications and also dating applications. For example, the Grindr and Blue Dog, they are like apps which are used by men who have sex with men to find sexual partners. Sex workers also use several apps to find potential paying sexual partners, clients. If you look at the right-hand side, you can see like in one dating app called Grindr, it even it has a feature like where I can enter. For example, whether I have tested and what is my HIV status, whether I'm on PrEP. So basically, the one way to see that dating app is it increases the chance of getting a lot of partners, but in another way, it actually also increases the awareness about HIV testing and HIV prevention. So NACO has also recently released, like just I think 1 or 2 years back, released guidelines on virtual intervention, especially focusing on what is called as a network operated model. So there are some guidelines available from NACO, which the target intervention they can actually use. And also there are like other virtual intervention funded by, for example, Global Fund, like NACO, which is a global funded program. And JHU, they are another saved in the virtual intervention program. So other NGOs, they are also like increasingly using virtual intervention to reach key population, especially men who have sex with men and sex workers. But however, the key challenges like which they have reported is the low yield, meaning you reach like say 100 people, you provide information in the apps, but only maybe, I don't know, like maybe according to the data, less than 10% may go for HIV testing. And it is hard to even track them because it's they are in the virtual space. It's difficult to follow up with that. Of course, Dr. That's also mentioned about like a PrEP, but just one clarification is nowadays like WHO talks about PrEP in terms of combination HIV prevention, PrEP plus condoms. So as part of a combination, because WHO also understands that STI may increase, so that is why like PrEP should be used along with condoms. So the counseling should be provided accordingly. So there have been some PrEP demo projects, demonstration projects in India as well, among FSW through Australia and also in Sonagachi. And also ICMR has conducted a PrEP demonstration project, and recently just I think like 1 week back in ASICON in Chandigarh, like Dr. Seema Safari, who was heading the PrEP demonstration project for MSM and trans women, she presented the key findings from that and showed that, and she told that it is shown as like the uptake is good and it is primarily safe. So no, actually, like she reported like almost like no adverse effects, and adverse effect 2 or 3 which were related only, not related to PrEP, some other adverse effects she reported. Of course, NACO has released technical guidelines on PrEP, so which can be used by the service providers. So that is available online. And some of the NGOs and CBOs, they already started providing subsidized PrEP or free PrEP, and many private practitioners, even some of you here, you will be providing PrEP. So both to senior discarded couples and also to MSM and trans women. And one regarding the post-exposure prophylaxis, you know about the occupational post-exposure prophylaxis, but after sexual exposure, whether post-exposure prophylaxis is available. So that's still a challenge faced by KPs. If a trans woman has undergone, say, forced sex, there's sexual violence experience, but when the trans woman goes to the government hospital, like for they will be doing other tests and STI and those things, but the post-exposure prophylaxis for HIV is not still available in the government hospitals. I'm talking about not occupational post-exposure prophylaxis, but post-sexual exposure prophylaxis in case of condom breakage or sexual violence. Okay, one particular theory which I have been using in my studies is syndemic theory. So syndemic theory could explain why there is high levels of HIV and high-risk behaviors among the key population, especially my focus has been on MSM and trans women. So basically it is something like this. So there are some social sexual forces, say societal stigma, discrimination and violence, which can contribute to psychosocial health problems like say depression, anxiety, problematic alcohol use, interrelated stigma, which in turn interact and can produce negative health outcomes like HIV risk. It can be increase in HIV risk, or it can be decrease in HIV testing, or it can be decrease in ART adherence. So those are the negative health outcomes. So this model, like we have, one is that through qualitative study, we have confirmed this model, like multiple stigmas faced by, say, MSM in this particular study, it contributes to what is called synergistic epidemics of depression, anxiety, problematic alcohol use, and self-stigma, which ultimately increases the HIV risk. So this is a qualitative study, but we have also done quantitative studies. This was among 300 MSM and 300 trans women. We have shown that there is syndemics of depression, alcohol use, and victimization, and it in turn increases the HIV risk. Again, from NACO's own IBBS data, along with NACO co-authors, we have shown that there is a co-occurrence of violence, victimization, drug use, and frequent alcohol use among men-sex with men. And these psychosocial problems actually interact synergistically to increase the HIV risk faced by MSM. So again, this is from NACO's data and published along with NACO co-authors. So demonstrating the importance of need to address the psychosocial health conditions to decrease the HIV risk faced by key populations. So again, this is just showing a similar model in which violence victimization contributes to drug use and frequent alcohol use, which in turn increases inconsistent condom use. So several of these studies have also been partly contributed to the NACO's white paper on trans people, in which NACO especially talks about the need to provide trans-specific services beyond HIV. So especially talks about mental health counseling and support which need to be provided, and also NACO talks about information and reference for gender-affirmative medical services, like referring trans people for gender-affirmative surgeries and gender-affirmative hormone therapy. So that's briefly we have seen about the prevention and of course about the focus on syndemic theory and how it can explain the heightened HIV risk among key populations. So coming to the HIV treatment, again this is from NACO's own data. You can see that out of the 100 people who initiated ART, among the heteros or trans women, the percentage is less when compared to men and women. Again, the last follow-up for trans women, again, NACO's data, if you can see that among trans people, like transgender women, the last follow-up is nearly like 2 times higher than that among the general population. So, from one of my qualitative studies, we have again shown that the intersectional stigma faced by transgender women, for example, as a transgender, a person may be facing gender identity stigma, sexual stigma, and also perceived HIV-related stigma. So this in turn again can contribute to the psychosocial problems, which can contribute to the negative health outcomes. So one important thing in relation to the trans people in this model is about the gender affirmation needs. So what gender affirmation means, there is one thing called social gender affirmation. If a transgender woman comes to you in the clinic and if she is coming in a saree, and if you are going to call that person in a male name and using male pronouns, that is going to hurt that person. So that is lack of gender affirmation. So you are not like providing social gender affirmation. This kind of, let's say, interaction with the healthcare providers can actually decrease the engagement with the ART treatment. So they may disengage from the ART treatment, and it can also decrease the ART adherence. So we have shown that this is the case through qualitative studies, and through quantitative studies also we have demonstrated that the lack of social gender affirmation in ART centers, it actually, like, if there is gender affirmation, it increases the ART adherence. You can see the diagram. And again, we have shown that depression actually negatively contributes to ART adherence. Depression decreases the ART adherence. Similar findings have been found among MSM living with HIV as well, like stigmas contributing to psychosocial problems, which in turn actually decreases the ART adherence. So very briefly about FDAs, I think I have 2 minutes. So NACO's logo has changed a couple of years ago. If you can see the NACO logo closely, you can see that There is also like addition of sexually transmitted infection. Like just a couple of years ago, this change has come. So basically now NACO is also trying to intensify the focus on STIs. So the recent technical guidelines from NACO on STIs, it has specific focus on key populations as well. For example, in chapter 2, there is a subsection on specific considerations for trans people, how to conduct clinical examination, how to take sexual history, like that. And one key gap even now is there is lack of awareness about vaccine preventable STIs among key populations. About hepatitis B, because hepatitis B is also can be sexually transmitted, especially in unprotected anal sex. So the awareness about hepatitis B and the need for vaccination among both MSM and trans women is suboptimal. And actually in the study which I mentioned, which Dr. Sagai discussed like just 1 week ago, couple of weeks ago, she complained that no trans women came for hepatitis B vaccination even if it was offered free. So the reason was not known, but still like that actually shows that we need to increase awareness about hepatitis B and also about HPV among the key population. So HPV obviously, you know, like it's not only about like say STI, but it can also prevent future cancer risk as well. So these are the key messages which I want to end with. Social sexual factors influence in mental health and HIV-related risk behaviors and outcomes. So which is pointing out that we need to focus on stigma reduction and mental health screening and management. And also we need to move beyond the HIV issues. We need to address the specific needs and issues of key populations. For example, the gender normative needs of trans women, for example. And as healthcare providers, we need to be non-judgmental and we need to provide non-discriminatory care for key populations. Thank you.
Thank you very much, Dr. Venkatesan Chakrapani. Sir, you have actually know, you also gave the definitions about transgender women as well as men. You gave us guidance related to social media use as well as misuse, and also you guided us about pre-exposure prophylaxis as well as post-exposure prophylaxis. And at the last, you told us about hepatitis B and HPV vaccinations. Thank you very much, sir. Sir, we can have questions, sir. We can have only one question for you, sir, as well as one question for the Day-1, sir.
Hello. Good morning. This is Dr. Sarcopenia from Surat. Congratulations for nice presentation from you and Dr. Das, but both are contradictory. Talking about PrEP, still NACO, we have recommendation of TRG. Dr. Saha has already documented the one study from Nari, same way from Sonagachi and Aswadia also. We have our own data, but still Dr. Das said that NACO is not ready to implement PrEP. Okay, that's good. But I'm talking one more group, that is serodiscordant couple. You are in favor of key population, I am with you, but one group is left, serodiscordant couple. So NACO is still keeping eye closed for serodiscordant couple for providing free PrEP from government facility. My question to both of you. Thank you.
So I will leave that question to Dr. Das because he is a good question to answer. Yeah, it is like an executive decision, right? So he has to answer.
See, let me give you one example. If I go to a government hospital in Ahmedabad and I am having sore throat, the government doctor may prescribe me amoxicillin. I am not satisfied with amoxicillin. I want some 4th generation latest antibiotic. I can go to a Medanta or Apollo hospital and get that antibiotic. It is as simple as that. If anyone wants to have PrEP, he or she may go to a private sector and take the PrEP. In government sector, under the Government of India program, we will carefully evaluate the cost effectiveness of PrEP, the efficacy of PrEP, and only then we will introduce it. we cannot introduce anything which has been a failure in the African countries. I repeat, it has been a failure in the African countries. If I want to have a knee replacement and I go to a Sarkari hospital, that surgeon may advise me or prescribe me of a material which is of optimal quality or minimal quality. I am not satisfied with that quality. I go to the top level corporate hospital and I get the best imported knee implant and I get it.
Sir, here we are talking about PrEP only, and that's the zero discordant couple.
Zero discordant couples, how many, what is the percentage of zero discordant couple and in which age groups?
Yeah, sir.
Has there been a national level survey of what is the percentage of HIV among zero discordant couples and what is the efficacy of PrEP in those zero discordant couples?
Sir, I can give you data about Surat.
I want a national level data. सरकार में जब कोई प्रोग्राम होता है ना, मैं आपको आप लोगों को हिंदी में समझा देता हूँ. भारत सरकार जब कोई प्रोग्राम लॉन्च करेगी तो पूरे देश के लिए करेगी. अहमदाबाद के लिए या सूरत के लिए या नई दिल्ली के लिए नहीं करेगी.
Thank you. I think we should restrict it to the speaker. Comments from the audience and to be answered by the speaker. Thank you. Dr. Franco, Professor.
You mentioned that no vaccinations for transgender women for hepatitis B. What about for papillomavirus, given that there is a very low screening program for anal cancers and so vaccination will be relevant?
Thank you for the question. I think I also pointed out that people who reported that they have taken HPV vaccine among trans women is 2.6%. So it's very, very low. The awareness about HPV vaccine is very low among the key populations, and especially among MSM and trans women, where there is also, like, if they have a risk of, let's say, anal genital warts, which can potentially later trying to turn into anal rectal cancer. Even among them, the risk awareness and the need to take vaccination is very much less. We don't have any dedicated educational campaigns to increase the awareness about HPV vaccinations among them. And also, you know that they need to take the HPV vaccine within a particular age, right? So they are supposed to take before less than at least for MSM they have increased the age up to 25, 26 they can take. So that is another reason we need to catch them young. So we need to provide this information at a very early age. Thank you.
This is last. I think that was a good input provided that a lot of our NACO program, more than 85% is being self-funded, unlike what it used to be earlier. We were talking about CD4 count and follow, viral load, and then follow. Now we come across a lot of treatment failures because of non-adherence. Is it not worthwhile NACO considers to implement phase-wise genetic susceptibility testing for select cases so that we can be very choosy and give the right kind of treatment when there is scenarios of treatment failures? Thank you.
We are already going to launch the drug resistance testing. We will start at AIMS Delhi and NIMS Bangalore. Professor Ashwin is here.
The speaker has left the stage, so we have to close the session.
So let me answer his questions. We are going to start drug resistance testing among primary acquired as well as secondary on treatment. Okay, let me also, because most of you are clinicians, so let me give you a social background. The reasons for non-adherence. Most of the patients who are from the poor economic background who come to as migrant laborers or seasonal workers to the urban centers, after their contract is over, they go back to the villages. There have been cases, because we monitor under the program, that a person starts his treatment, he is registered at an ART center at Bihar, and he is given a particular ID, the information. That person, he migrates to Mumbai or Delhi or suppose say Ahmedabad. Then at his ART center at Bihar, he is found to be LFU or he is not coming for treatment. He comes to Ahmedabad, he gets himself registered under a new name or a new ID. He does not disclose that he was already taking treatment. treatment at Bihar. And so there are a lot of duplicate cases also in the system. So we are trying, that's the reason I mentioned that we are trying to do it, match that with the ABA ID system, that one health ID will be can be accessed throughout the country. So once that is operationalized, the cases of LFU and loss to follow-up or who have discontinued treatment, that will reduce. There has been n number of cases, especially from the lower socio-economic background. They start their treatment at one center, they migrate to some other city, and then they re-register themselves. So at one center they are seen as counted as loss to follow-up in the other. And regarding drug resistance testing, we are going to start it shortly.
Thank you very much. Thank you very much, Dr. David sir, Dr. Uday Babu sir, Dr. Venkatesan sir. Thank you very much all the participants. We are closing the session. Thank you.
Thank you very much. I request the chairs to kindly hand over a token of appreciation to our speakers, Dr. Das and Dr. Chakraman. Which is a plenary. I would request Dr. Kumarasamy and Dr. Harsh Toshniwal to chair the next session.
Good morning, everyone. So, welcome to our first plenary. As clinicians, we all know that antiretroviral therapy is lifelong. How difficult our patients are struggling to take these oral pills every day. So, this is time we need other remedies, other technologies, and also to combat all these issues faced by our patients. Now, we have this sort of long-acting antiretrovirals. Some of you know that, like cavitrotide, Bengaluru, and also Lenacapavir, all been already approved for use. And this is also being used both for treatment as well as for prevention in risk settings. And it's time, it will be introduced anytime soon. And also now, we heard from the NACO leadership, they are very keen to observe this and introduce to our NACO program. So this plenary is timely for India on long-acting antiretrovirals for treatment. It's going to be done by Dr. Jürgen Rockström. You will hear his, three profiles.
ASICON welcomes Dr. Jürgen Rockström. Dr. Rockström is the head of infectious diseases at the Department of Medicine, University Hospital Bonn, Germany. Dr. Rockström's career combines significant clinical practice with impactful research, making him a key figure in the field. He has held numerous leadership positions in prominent organizations, including chair of the German AIDS Society, UNAIDS, the German National AIDS Advisory Council, and president of AIDS. Dr. Rockström's influence extends internationally through his involvement in conferences like the World AIDS Conference and his work
morning, and thank you first of all to the AIDS Society of India for the kind invitation to speak here today. My topic is long-acting ARVs for treatment. These are my conflict of interests. And when you think yourself or picture yourself in 2025, you can say, are there any real challenges left in HIV therapy? Most people, when they take potent integrase second-generation based therapy as first-line therapy, over 95% become undetectable. There's an overwhelming body of clinical evidence that established U equals U, undetectable equals untransmissible. In the rare event of virological failure, hardly any risk for resistance development exists. We speak of a near to normal life expectancy for people living with HIV under antiviral therapy that started early enough. And the discontinuation because of adverse events has decreased to below 2% because of the increased tolerability of these modern regimens. So why could we potentially need long-acting antivirals? And already in the talks I listened to, we always talk about the remaining issues of adherence and stigma challenges. And I think that remains true even in the setting of improved regimens. And there are issues around overcoming treatment fatigue of a lifelong therapy. I think that many individuals get infected when they're sexually active in young years. There clearly is a wish from the patient side for treatment simplification. Individuals don't want to be reminded of HIV every day. And there has to be an alternative for individuals who have difficulty swallowing tablets. And let me picture this whole stigma and disclosure issue with one patient of mine, which was a lady from Africa who had a child who was HIV negative, and she did not want to disclose her HIV status to her child. She was living in a community where HIV meant to be put out of the society, out of that group. And so for her, it was super important not to disclose her status, not have someone find her medication. And I think that's some of the individuals we have to think of when we talk about long-acting. There have been surveys in the past looking at interest potential of antiviral therapies, and this is from South Carolina, and it's interesting to see that most interest was generated about taking a single pill once a week, but also shots in the clinic every other month were a highly interesting alternative. So there clearly is, from people living with HIV, a strong interest in these new modalities of administration. And what are the challenges people living with HIV face? Well, they worry that taking HIV medicine every day increases the chance of revealing their HIV status. That is a concern for almost 40% of individuals. Taking HIV pills every day cues bad memories, 35%. Taking HIV pills every day is a daily reminder of HIV and has impact on quality of life. And difficulty swallowing pills still is also a common found feature. So in this process of developing new modes of administration, there are already two combinations which are available, or let's say one combination and one single drug. And that is the combination of cabotegravir and rilpivirine, so a second generation integrase inhibitor in combination with an NNRTI, which is administered every 8 weeks intramuscularly. That's a little bit challenging because you get an injection in one buttock and then the other buttock, so it's 2 injections. It's painful and not that easy. Lenacapavir is a little easier, the administration is given subcutaneously every 6 months. Now, there were many pivotal trials, and I'm not going to go through all of that because of the time constraints, but in the initial ATLAS trial, which was comparing continuation of oral HIV treatment versus once monthly injection with cabotegravir rilpivirine, demonstrated non-inferiority, and the continuous ATLAS 2M study then looked at the outcome of once monthly versus 2 monthly injections. And you can see that the virologic success rates were comparable. So that sort of established the wider interval. And I think it's a fair point that the more frequent you have to inject, the more frequent you have to see the patient. That can be a real burden for busy clinics with 4,000 or 5,000 individuals under care. So obviously, the longer their interval, the better it will become. And this study clearly showed that there was comparable efficacy between the 4-weekly and 8-weekly administration. Note though that in all of these trials, there was a very low, but there was met criteria for confirmed virological failure, which was a little bit higher at week 152 for those who had 8 weekly injections, which was 2% versus only 2, something less than 1% in the 4 weekly administration. So the more you push the interval, it probably does shift a little bit your risk of potential virological failure. In individuals who developed a confirmed virological failure, there was a higher risk for failure and resistance development in the presence of at least 2 baseline factors, including proviral rilpivirine resistant associated mutations. So either by getting infected with the resistant containing variant or from previous therapies, the H1 subtype A61, a higher BMI of 30. So 2 of those factors were associated with an increased risk. All of these people who had confirmed biological failure, though, met the injection time, so it was not related to too big of a delay administering corresponding intramuscular medication. One of the big concerns in clinic initially was, how is that going to play out over time? Are you going to see more injection site reactions? Are people going to stop because of the injection site reactions, because it's intramuscular injection? And you can see that the number of individuals withdrawing for injection-related reasons is very low. It's around 2%. So that really doesn't play off. And the lady I talked to you about, who has the HIV-negative child, who is afraid of disclosing her status to her child, is now in year 7. She participated in all these trials and is doing very well and really does not want to change her medication. Interestingly, a study was done in the context of switching to long-acting cabotegravir rilpivirine in virologically suppressed adults in Africa. We always think in Africa, resource-limited setting, results may be different, or more challenging surrounding factors. But most interestingly, the efficacy of switching individuals to the long-acting regimen was associated with an extremely high response rate of 97%. So there were almost less confirmed biological failures than in any other trial. And that, although there were 14% individuals at baseline who had archived rilpivirine resistant associated mutations, 57% had the viral subtype A1, and 20% had a BMI above 30, so they had unfavorable risk factors. So these are very reassuring data, raise the question whether the identified risk factors are really the ones responsible for developing biological failure. In the Netherlands, Emery Wenzing, who's a virologist, gathered all the data on all people who received long-acting cabotegravir rilpivirine and compared the overall response rates between oral therapies and long-acting therapies. Saw no difference in virologic suppression rates, but there were 5 individuals who developed virological failure, although they had less than 1 or no risk factor at present. And I think that is one of the big concerns which remains, is that although virological failure is very rare, probably in the range of 0.3, 0.5%, cannot exclude that even if you give the injection every 8 weeks on time, you use the right length of the needle, you may still see virological failure. And that's why in clinical practice, I say to a patient, if he wants or she wants to receive long-acting, I say there is a little risk of virological failure, which you do not have with a dolutegravir-based regimen. So that's something to keep in mind. But most patients are so driven by the wish to change their circumstances of how they take antiviral therapy that they go for the option of long-acting anyway. One area of debate and interest has been the use of long-acting in more adherence-challenged patient populations. And if you think about it, it makes perfect sense, right? So if you have someone who's never able to take a tablet every day, if you would be able to at least see him every 8 weeks and give an injection and ensure continuous drug levels, wouldn't that person perform much better virologically? Makes sense. It's in your body. You can't say, I'm not going to take it tomorrow. It's in your body and it's going to stay for a while. So in North America, which is obviously undergoing quite some changes these days, there is a high amount of individuals who are living under difficult circumstances. So high amount of drug use, high rate of homelessness, and so they took these adherence challenge population, mostly from San Francisco, and first tried to get them on oral therapy with all kind of adherence training and interventions, including economic incentives. That's something which is done in America in the context of clinical trials, so people get food vouchers or money to encourage that they come for their visit. That's something which I think would never work in the German context. And then after this initial phase with the economic incentive, people were randomized either to continue the oral therapy or to switch to cabotegravir, rilpivirine. And you can see that this was an interesting patient population. 30% were female, 5% transgender, high amount of racial diversity. And you can see that although they were on oral therapy, still there was quite a high number of individuals who did not take their therapy. Only 32% were less than 200 copies, so quite a high number were replicating. 40% even had a viral load above 100,000 copies. And when they then switched to their corresponding regimens, you can see that the people who received cabotegravir or rilpivirine were doing very much better. So virological failure rates were much, much lower in the cabotegravir rilpivirine arm. Treatment-related failure was much lower than the cabotegravir rilpivirine arm. So the suppressive cabotegravir rilpivirine regimen turned out to be superior to oral therapy. And that just underlines that if you have an adherence challenge population and you get them at least to show up for the injection, you're going to have continuous drug levels and as such a higher antiviral efficacy. There were very few individuals who developed virological failure, because you could argue adherence is an issue. Aren't you worried that if people don't show up for the next injection, there's more resistance development? But that was not necessarily seen. There were some cases, but not very many. This idea has been also brought forward in Monica Gandhi's Ward 86. This is a ward which is very much specialized in taking care of people living with HIV who are coming from very difficult social background, and who are not controllable with oral therapies. And so again, these individuals who are difficult to get to take a tablet every day were started on cabotegravir rilpivirine, and indeed over 80% remained suppressed with that regimen at week 48. So just telling that replicating people, which is against the phase 3 development program. Remember that cabotegravir rilpivirine is licensed in the label as a switch regimen for suppressed patients. But what they're doing is taking this option sort of outside of the indication it's licensed for and using it in individuals with very strong adherence challenge. You can see that in that population, drug use was 71% and 53% had unstable housing or homeless, clearly underlying why there are adherence challenges in that particular combination. So what has happened from these two trials, the San Francisco Ward 68 experience and the Latitude trial, which was a randomized ACTG trial, was that guidelines from ISUSA have changed, now supporting that if individuals who have intensive follow-up and case management service, that injectable cabotegravir rilpivirine may be considered for people with viremia, so outside of the license indication, when they meet one of the following criteria: unable to take oral ART consistently despite extensive efforts in clinical support, high risk of HIV disease progression, so low CD4 count below 200, or a history of AIDS-defining complications, and the virus should be susceptible to both cabotegravir and rilpivirine. This is what we're going to see, I think, in many guidelines popping up. So far, it's been ISUSA guidelines. EX guidelines are currently being revised, but I wouldn't be surprised if there would also be sort of a pledge to use this in that very well-defined patient group. So in summary, I think with this sort of available cabotegravir option, we have on the pro side a flexible therapy which allows to overcome issues around GI problems, swallowing difficulties, can really help us in individuals who face HIV stigma, can overcome treatment fatigue, may overcome challenges which come with shift work or frequently changing time zones if you're a flight attendant, for example, and may overcome adherence challenges. I think the con still is that there is a higher risk for virological treatment failure with resistance development compared to second generation integrase inhibitor therapy. It's only in the range of probably 0.3 or 0.5%, but it is something which may happen. And clearly the implementation has been difficult with regard to logistical challenges, getting all the injections, watching people after injection and so forth, and adherence to the injection schedule still could be challenging. With regard to lenacapavir, which is given every 6 months, that's obviously a super target for future long-acting combinations, but we don't have readily available many different options right now. But there has been a case series of people, again from Monica Gandhi's group, looking at individuals who already had NNR type resistance, so didn't qualify for cabotegravir. They received lenacapavir and cabotegravir, and again, that worked exceedingly well. So in a very challenged patient population, this worked very well in 34 individuals, with 94% being suppressed. So really, I think, showing that this combination holds promise and should be explored in addition. There are many other long-acting agents in development, including ultra-long-acting cabotegravir every 4 to 6 months. There are prodrugs of cabotegravir, which may be given every 12 months. There are new capsid inhibitors, which have been developed as long-acting agents. Then there is the combination of lenacapavir with broad neutralizing antibodies. And then there are quite a plethora of drugs which can be given once weekly as an oral. And obviously, that would be easier from an implementation standpoint, just one tablet. And remember, we're doing that in rheumatoid arthritis with methotrexate or osteoporosis treatment with biphosphonates. One tablet per week is sufficient. This is being currently investigated with a translocation inhibitor, islatravir and lenacapavir in an oral formulation. And then we have also new integrase and lenacapavir prodrug formulations, as well as other drugs which are also going in the same direction. This is from the prodrug of cabotegravir, different formulations, and you can see from the PK curves that, and this is in the animal model, so it's very early days, but you can see continuous drug levels, promising that this may be administered only once a year, so quite exciting if it ever makes it also in humans. Looking at islatravir, lenacapavir is the first once-weekly oral combination. You can see that in this combination, the response rates were, compared to bictegravir and FTAF, were very high, 94 over 92%, so super response rates, no resistance emergence. Tolerability was very, very good, very few discontinuations, and the lymphopenia, which was seen under higher doses of islatravir, did not occur in this 2 milligram formulation. So it looks as if it's very safe from a lab standpoint. The only severe adverse event was a significant increase in liver enzymes in one individual who developed a hepatitis B. And remember, if you're giving a dual therapy like islatravir and lenacapavir, you have no anti-HBV drug underlying, and that's why I think the talk for mine was so important, highlighting the need of reminding everyone that we should do hepatitis B vaccination, because the more new combinations we're going to give in the future, the higher the risk for HBV will become if people are not vaccinated. Lenacapavir plus broad neutralizing antibodies is also causing some excitement because people who have been suppressed for quite a while receive lenacapavir and broad neutralizing antibodies as an infusion, and then treatment is discontinued. And indeed, in this study, which looked at people who were susceptible to one of the two, either ZAP or TAP, so these are two different broad neutralizing antibodies. We know if you one broad neutralizing antibody, you're pretty likely to develop resistance. So you need to use two, but what if one of the antibodies is susceptible and the other one isn't? It still would work very well if you used higher doses of the broad neutralizing antibodies. This would allow to have someone on therapy, given Lenacapavir, given an infusion with the broad neutralizing antibodies, and then stop therapy altogether for 6 months, and you would have a complete 6-month free point of no HIV medication. The only issue is infusion, expensive, needs room, a line, implementation-wise difficult, the price is going to be high. I don't really see how this will be implementable, but it clearly would offer a new option. Other compounds in development, the novel integrase inhibitor from Gilead, GS1720, also active against certain integrase mutations, very good median T-half of 9.3 days, so clearly also developable for once weekly. And then there's a new Lenacapavir prodrug, which could also be given in a smaller tablet size, also as a once weekly combination. So those two drugs are currently moving into phase 2 as the new two-drug therapy. So in summary, long-acting injectables represent a new additional option for HIV treatment, which can be instrumental in overcoming stigma or disclosure issues. There is a very low but existent risk of virological failure, even in fully adherent individuals, and I think that's something people need to know. And that virological failure is associated with a high risk of resistance development. There is a whole range of new long-acting agents in development, be it intravenous, intramuscular, or subcutaneous. And they're all showing impressive PK results, promising 6 or even 12 monthly treatment intervals, and different once-weekly oral therapies are currently in phase 2 and 3. So I'm pretty sure that probably by 2 years we're going to have a first regimen with one weekly option available. With that, I thank you for your attention and happy to take any questions. Thank you. No questions.
Thank you, Dr. Sir, for wonderful account, giving a wonderful account on long-acting injectable antiviral drugs, which will manage many challenges which we are facing every day in our population of HIV. It will also help reducing your challenges of stigma, will reduce your daily keeping the stock of the medication. Many people cannot take oral medication. It will be boon in situations like lockdown. You take one injection for 6 months. We have many new drugs which are now available oral once a weekly. So all that detail we got about the Capricsa, Lenacapavir, and Lenacapavir. Thank you very much. Since it's a plenary session, we will not raise any question. If you have more information you want to know, you can always approach. Thank you very much.
I would request our chairs to kindly hand over a memento to Dr. Longstraw. I would also request Dr. Kumarasamy to hand over a token of appreciation to Dr. Harshbhushan. Thank you very much. We will be skipping our tea break as we are running a little behind schedule. The tea coffee is available on the left side of the hall, so you can always go in and just grab a quick cup of tea and coffee. We will move on to our next session, which is HIV cure, remission and vaccines. Are we there yet? I would like to call upon our chairs for the session, Dr. Jyoti Dhar and Dr. Meet Tharsandia.
Dr. Keith.
Hello everybody. I'm grateful that all of you are back in the hall, and please enjoy your coffee and we continue. May I welcome to the session as well. Dr. Masini, that session we are not doing it at the moment. So we request Dr. Leela Mansoor from South Africa to please present herself to the podium. And she will be speaking on Lenacapavir in prevention, and subsequently we'll have Dr. Mathai speaking to us about vaccination. So, Dr. Mansoor, can I request you to...
ASICON welcomes Dr. Leela Mansoor. Dr. Mansoor is a senior scientist and co-principal investigator at CAPRISA, a leading AIDS research center in South Africa. She has over 18 years of experience in clinical trials, focusing on HIV prevention technologies for young people. Dr. Mansoor's research interests include HIV prevention, adherence support in clinical trials, and social science research related to patient understanding and perceptions of medicine and disease. She has led and co-led numerous significant studies, including trials for gel, oral PrEP, and long-acting PrEP methods. Dr. Mansoor is skilled in developing and implementing novel approaches to adherence support, particularly for low literacy and research-ready populations. We look forward to hear her talk on Lenacapavir intervention.
Can I request everybody to be silent, please, if we can help it, so that Dr. Mansoor can be heard. Thank you very much. And can we close the door at the back? Thanks. Thank you, Dr. Mansoor.
Good morning, everyone. You don't actually have to see me. As long as you can hear me, that should be fine. So I'd like to start off by thanking the meeting organizers just for allowing me to present at this amazing conference. My presentation this morning will look at Lenacapavir for HIV prevention. Okay, so sorry, okay, Okay, so let's talk about what is Lenacapavir, or otherwise known as LEN. So Lenacapavir is a first-in-class, multi-stage HIV capsid inhibitor with a high potency and a long half-life, supporting twice-yearly subcutaneous injections. As you know, the HIV capsid core contains and protects viral RNA and enzymes, all of which play central roles in HIV replication. LEN targets various stages of HIV replication, specifically the nuclear transport, virus assembly and release, and capsid core formation. And of note, even though LEN acts both before and after HIV integration, it is most potent in the pre-integration phase. injectable pre-exposure prophylaxis options like LEN have shown promise in overcoming barriers to adherence. Sorry, both of us are using the mouse at the same time. Okay, so LEN is currently being researched in the PURPOSE program, which is the most globally, racially, ethnically, and gender diverse program conducted to date. This program is being sponsored by the pharmaceutical company Gilead Sciences, and the first two clinical trials, PURPOSE 1 and PURPOSE 2, evaluated the safety and efficacy of twice-yearly subcutaneous Lenacapavir for HIV prevention. In this presentation, I will focus on these two phase 3 clinical trials. PURPOSE 1 enrolled over 5,000 cisgender adolescent girls and young women in 2 African countries, so in South Africa and Uganda. And this is the first study to gather data on adolescent girls, pregnant and lactating women, and infants in the primary phase 3 protocol. And PURPOSE 2 enrolled more than 3,000 participants in 7 countries across North and South America, Africa, and Asia. These participants were gender diverse, including adolescents, men who have sex with men, transgender women, and transgender men, as well as gender non-binary people. In PURPOSE 1, participants were randomized in a 2:2:1 ratio to receive either subcutaneous LEN 6 monthly or daily oral Descovy, which is emtricitabine and combined with tenofovir alafenamide, also known as FTAF, or to receive be the control arm, where they received daily oral Truvada, which is emtricitabine combined with tenofovir disoproxil fumarate, also known as FTDF. The study used a background HIV incidence rate, which was the HIV incidence expected without PrEP, or that would have been expected in a placebo group, otherwise known as the counterfactual HIV incidence. The background incidence rate was calculated by testing women for HIV at a screening visit, and the positive samples were tested using a recency assay, which determined if people had acquired HIV recently, almost 3 months just before the 3 months within the start of the study. The primary analysis compared this background HIV incidence to that of the study drugs, both LEN and FTAF, and I will go into more details about this shortly. The PURPOSE 2 design replicates that of PURPOSE 1 in a different population. However, in PURPOSE 2, FTAF was not evaluated along with LEN, and this was because in 2020, Gilead Sciences presented the results of the DISCOVER study, which was a clinical trial that evaluated the safety and efficacy of FTAF for PrEP compared to FTDF in men and transgender women who have sex with men, showing a 99.7% of participants taking FTAF stayed HIV negative. So delving into the data, the overall baseline demographics and clinical characteristics were balanced across the randomized groups in both studies, PURPOSE 1 and PURPOSE 2. In pre-specified interim analysis, 50% of participants in both studies had completed more than 52 weeks of follow-up, and there were 0 HIV infections in the group of participants who received LEN in PURPOSE 1, and only 2 HIV infections in those who received LEN in PURPOSE 2. Furthermore, in PURPOSE 1, there were 16 infections in the FTDF group and 39 infections in the FTAF group. And in PURPOSE 2, there were 9 infections in the FTDF group. The primary analysis compared the background HIV incidence rates to the incidence rates of the study drugs. This resulted in the HIV incidence rate ratio showing that LEN reduced HIV infections by 100% in PURPOSE 1 and by 96% in PURPOSE 2. Additionally, in Purpose 1, FTAF was not significantly lower than the background HIV incidence rate. So looking at the secondary analysis of the results, which compared the incidence rates of each investigational drug against that of the active control, Len reduced HIV infections by 100% in Purpose 1 and by 89% in Purpose 2, compared with daily FTDF. And the HIV incident rate for those in the FTAF group was not numerically different from the FTDF incidence rate in Purpose 1. So at the beginning of this presentation, I mentioned that injectable PrEP, and the previous speaker said a similar thing, that injectable drug products have shown promise in overcoming barriers to adherence. Adherence to injections in both Purpose 1 and Purpose 2 were high and consistent at over 90%. Even though adherence to FTDF was high in Purpose 2, the graphs show that there was a decline in oral tablet adherence over time in both studies. Notably, in Purpose 1, a significant dose-response relationship is seen with a lower chance of HIV infection associated with medium or high adherence to FTAF compared with low adherence. In terms of safety, both Purpose 1 and 2 studies have shown that Len, FTAF, and FTDF are safe and well tolerated. The adverse events that occurred in these two trials were consistent with those in previous Len, FTAF, and FTDF studies. For example, nausea, headache, vomiting, and some STIs. Pregnancies were common in Purpose 1 as contraception was not a protocol requirement, and pregnancy rates were similar across the arms. In addition, pregnancy outcomes were similar across all three arms and comparable to those seen in a normal population. In Purpose 2, the frequency of adverse events and laboratory abnormalities was similar in the active Len and control arms, with the exception of changes in the glomerular filtration rate, which was significantly different at week 26 and week 52 visits. These two tables list the number of adverse events in each study arm in the Purpose 1 and Purpose 2 studies, with the percentages in brackets demonstrating that AEs were similar across the different groups in each study. There were 6 deaths in Purpose 1, all in the FTAF group, and none were related to the study drug per investigator discretion. And there were 4 deaths occurred in the Len group and 2 deaths in the FTDF group of Purpose 2. And again, none were related to study drug per investigator discretion. And just to give you some idea of what these deaths were, they are mostly vehicle accidents, suicide, there was some domestic violence, so strangulation, etc. Injection site reactions were considered separately from adverse events in Purpose 1 and Purpose 2. And Len is injected into the subcutaneous space and forms a drug depot that may be palpable under the skin as a nodule, but is not always visible. As the drug elutes, the depot gets smaller and the nodule resolves or substantially reduces in size before the next injection. As indicated in the graphs, the frequency of injection site reactions, including the nodules, decreased with subsequent doses in both studies. And of note, discontinuations related to injection site reactions were low, and were generally, these reactions were very well tolerated. So following the analysis, or following the results from the interim analysis, participants were unblinded to their study arm and were offered active Len injection. Both protocols have been amended to extend the open-label extension phase from the originally planned 1 year to providing Len to participants until local access. Sites are currently awaiting ethics approval for this to implement this amendment. So where do we go from here with Lenacapavir? Gilead Sciences has released a 2-part strategy that focuses on access and supply. They aim to establish a robust voluntary licensing program to expedite access to versions of LEN in high-incident, resource-limited countries. They also plan to supply LEN at no profit to themselves until generic manufacturers can fully support the demand. In a press release on the 2nd of October 2024, Gilead Sciences also signed a non-exclusive, royalty-free voluntary licensing agreement with 6 pharmaceutical manufacturers in 120 countries, and that includes India. These agreements include LEN for HIV prevention and for treatment in heavily treatment-experienced adults with multi-drug-resistant HIV infection. 3 of the 6 pharmaceutical companies who signed an agreement with Gilead Sciences are Indian companies, including Dr. Reddy's Laboratories, Emcure, and Metero. Gilead Sciences has begun global regulatory filings with their first submission to the US FDA on the 26th of November 2024. And in fact, earlier this week, we learned that the FDA has accepted the submission for expedited approval, meaning we should hear back from the FDA around June of this year. In addition, a second submission to the European Medicines Authority earlier this month on the 3rd of February 2025 was also made. And a positive opinion from the EMA will help expedite WHO pre-qualifications as well as other local regulatory applications. LEN has to be cost-effective in order to enable wide-scale access and rollout. At least 3 factors contribute to the estimated cost of this drug per person per year, which has been estimated by some to be between $50 and $200 US. Royalty-free provision to generic manufacturers is the first step that has been taken to reduce the cost. Secondly, technology transfers to more than one of these manufacturers promotes competition, which in turn will further lower the cost. And in addition, a higher demand for the product will promote a lower cost. In summary, LEN HIV prevention efficacy was found to be superior to both background HIV incidence and daily oral FTDF. We saw 0 HIV infections in participants receiving LEN in Purpose 1 and only 2 HIV infections in participants receiving LEN in Purpose 2. All 3 products were safe and well tolerated, and adherence to the LEN injection was high at greater than 90%. And currently, all trial participants are being offered open-label LEN injections. Of note, Lenacapavir was named the 2024 Breakthrough of the Year by Science magazine. I would like to thank the Purpose 1 and Purpose 2 trial participants, their communities, the investigators and science staff, Gilead's Global Community Advisory Group, and members of the Purpose 1 and Purpose 2 study teams for all their dedication and all that they have contributed to these incredible findings. And a big thank you to Gilead Sciences for making this research possible. If you would like to access links to the published manuscripts and supplementary information related to Purpose 1 and Purpose 2, you can go ahead and please scan the QR code on the slide. Thank you very much for your attention.
Thank you, Dr. Mansoor. I'm sure many of eloquent presentation of purpose, which was for many of us HIV practicing physicians, was probably one of the first studies where women were recruited, and it was much awaited and it didn't disappoint us. Thank you very much for your presentation. I'm sure many of you are itching to ask some questions, but can we go ahead with our second, can we do the questions after Dr. Mathai?
Now I would like to request Dr. Mathai to come to the podium. He will be talking about the adult vaccination, which is a very important clinical topic, but usually under-emphasized and under-practiced in clinical practice. So I would like to request Dr. Mathai sir to come to the podium.
ASICON welcomes Dr. Mathai. Dr. Mathai is the Dean and Professor of General Medicine and Infectious Diseases at the Apollo Institute of Medical Sciences and Research. He is the founder and past president of the Critical Infectious Diseases Society, demonstrating his leadership in the field. Dr. Mathai serves as the editor of the Journal of Global Infectious Disease and is a core committee member of the Indian Forum for Adult Immunization. Dr. Mathai has served as the president of the CMC Medical Alumni and is involved in initiatives like the Telangana State Action Plan for Containment of Antimicrobial Resistance and is the recipient of the Lifetime Achievement Award from the AIDS Society of India, recognizing his extensive contributions to the field. We look forward in hearing him talk on adult vaccination.
My topic has been designed as adult immunization, but I want to focus on the immunization of infected adults. Anyway, you had a sing-song presentation of my so-called credentials. This is the outline of my presentation, immunology of vaccination, for us to come on, all of us to come together with the same perspective, and some of the principles and guidelines in HIV for the vaccination among patients living with HIV. And the most important is implementation science, which is something that we should all practice in our lives. Now, aging, I think I'm one of the oldest in this group. It's unavoidable, okay? It's a natural process, but don't worry. There are people who are trying to retard aging. Ryan Johnson, for instance, is trying to retard his aging process, is achieving it by focusing on nutrition, exercise, and as well as certain biomarkers which is monitoring and certain drugs that he's taking. Now, we all have a considerable reserve. Please understand let's say the most prominent of our recently, the recent businessman who passed away, they are writing that he died as a result of age-related complications. Now, I don't know what is meant by age-related complications. Okay, he was okay the previous day and next day he dies. Okay, so you must understand that we have a considerable reserve, and these reserves can come down gradually. On top of it, you go and give them certain drugs, the renal functions, for example, they can decrease rapidly. So if you have certain infections and you've got certain antibiotics, your reserves can come down rapidly. So nobody knows the definition of senescence. Brain, does it mean have to use of senescence? Yes, maybe. But fundamentally, we should have a biological definition of aging. We do not have what is the cutoff age. Well, you retire at the age of 16, now the risk is 65. Can you go on to 75? I intend to go on to 83. I'm 73 today, so I think I'm going on, I will go on till 73. Having said that, you should make sure that you prepare yourself in order to prevent certain comorbidities, particularly infections which are vaccine preventable. Now, if you look at adult immunization, we are starting from childhood. I'm not touching childhood. I'm not touching immunization in pregnancy, but looking at adults as well as elderly or vaccinations in the older population. Now, there are 25 vaccines. I've excluded dengue, malaria, chikungunya, anthrax, etc. These are the vaccines that are available in our country, in the world today, and some in our country. Now, what is important in HIV is those marked in red. Okay, hepatitis A, influenza, EPT, hepatitis B, human papillomavirus, zoster subunit vaccination, and corona, typhoid, and pneumococcal vaccine. So I'll just focus on these aspects. In the elderly, antibody responses are weak. Why? Senescence of the immunological system, the thymus gland atrophies, decline faster, long-term protective efficacy is not there. So it's better that you protect yourself at a younger age when your memory cells are, when your T cell and T cell memory cells are intact. And then now new adjuvants are coming up, new vaccines. The mRNA vaccine that has been discovered is something, is a game changer. Now we've got vector-borne technology, we've got nucleic acid technology. They're all game changers in vaccines, delivery, the vaccine preparation. Now, I'm not getting into these aspects, but for you to understand that following a vaccine, there is a primary response in a healthy individual. What now we call it as T-cell independent and T-cell dependent. I'll just quickly go through that. For a vaccine to have well, you need your TB activated. Now, if the T-cell activated B lymphocytes produce much better or much more efficient or even a larger clonal expansion of the protective antibodies or neutralizing antibodies to take care of the onslaught of the new organism that enters the body. Now, it's all a question of lymph nodes. You need your lymph nodes. Now, when I ask my medical students how many lymph nodes do you have, I can count 120 lymph nodes in the human body. And what is, 800 lymph nodes in the human body, and only 120 are palpable if they are enlarged. If they are not enlarged, it's not palpable. Now, what happens is whether you give it in the arm, whether you give it in the nuclei, all of these go to migrate, antigens migrate to the lymph node, and then to regional lymph nodes, and then they start on the amplification system there, and then in the terminal, from the terminal cell of the lymph nodes. So if your lymph nodes are atrophied, if the lymph nodes are not functioning well, or if you do not have sufficient T lymphocytes in your lymph nodes, you are unable to get T lymphocyte-mediated antibody production, which is essential for creation of all of your neutralizing antibodies. So T-cell dependent antibody production, there are various steps, you will not go through it, but you can have the slides in the postgraduate student, take it free. And then you go on step 5, proliferation of B cells. It's actually the B cells and the clonal expansion that give you the protection. Now you can, and you have memory. The T-cell mediated polyclonal expansion of the B cells gives you memory. If you don't activate it through the T cells, then it's predominantly the B cells and the memory is not long lasting. So what happens in HIV induced? Reduced CD4, T cell help is not there. Reduced genetic process responses, reduced B cell numbers and function, and therefore reduced antibody production. Now, T cell independent antibody production basically just asks the T cells to produce the antibodies, which is the bacterial polysaccharide. I am showing this with reference to the polysaccharide vaccine and the conjugate vaccine. Now, what happens in the pneumococcal vaccine? Okay, you've got the PPSP, polysaccharide vaccine, and you've also got the protein conjugate vaccine. The protein conjugate vaccine stimulates the T cells as well. The polysaccharide vaccine doesn't stimulate the T cell. That's why you don't give PPSP in infants or in children less than 2 years age. PCV you can give it in 2 years age. Now, HIV individuals are more prone to invasive pneumococcal disease. Invasive is meningitis, of course, pneumonia, septic gland meningitis can be arthritis, etc. And they can get recurrent. We all studied that recurrent pneumococcal disease was a manifestation of AIDS-related complex. And so you need to protect them against pneumococcal disease. So which vaccine would you like to choose? Yes, I would like to choose the equivalent PCV. Now, can I give PCV PPV-23? Yes, you can give, but it's better to prime them with PCV-13 and then give them a PPSV-23 because it contains 23 valent. It's a 23 valent and contains most of the pneumococcal types. There are 100 or so. The 23 or 40 pneumococcal types. It covers more of them. So you get a better spectrum and a more potent action. So in HIV individuals, yes, we give them PCV-13. Now, 4 months later, 6 months later, or 1 year later, and it's all this arbitrary numbers. 4 months later, 6 months later, give them a dose of PPSV-23. Now, then we go on to typhoid. I received food eater. Yesterday I wanted to get some water pump. But I was looking around for some water pump, but I didn't find. But I immunized against typhoid. Okay. I've taken this, and what about the HIV individual? They are also quite likely to get typhoid because typhoid typhoid is endemic in our country. And what would you like to give them? Well, we are injecting a polysaccharide vaccine, safe, it doesn't multiply. Hepatitis A, I'm sure that if you have the trademark that you are an Indian citizen, all of you will be positive for hepatitis A antibodies. Because we've got fecal contamination in our sewage, and we will be getting, we would have had this hepatitis A sometime in our life. But it's better that the patient, the HIV individual, gets this immunized against hepatitis A, because if you've got an existing alcoholic liver disease cirrhosis due to B virus or C virus, you don't want to flare up with hepatitis A. Hepatitis B, yes, it is mandatory. Do we check for hepatitis B status? Do we check for core antibody status? Do we check for the, the HPS, antibodies levels? We don't do that. But it's much cheaper to give the vaccine. And 1 dose, 2 dose, 3 dose, 4 doses, yes. We want to double the dose. Normally we take 20 micrograms, we want to take 40 micrograms antigen, do so. So it all depends on hepatitis B. B must be covered. Of course, B is for everybody. Hepatitis B vaccine. Now let's talk about the flu. The pandemic flu changes its antigenic code every time, and we try to prepare Northern Ministry of Vaccine, Southern Ministry of Vaccine. Where do I give the vaccine? We don't have seasons of the year. We have got only rain, more rain, and summer. Now where do I give the vaccine? I give the vaccine sometime before the rain comes. Because potency is there for 20 days. We get antibody level against the basic influenza. How many valent, trivalent, quadrivalent? It's what WHO decides, and we keep that available vaccine out there. But also, please remember the birds also eat their food, and they will keep changing their antigenic structure as such. How much H1N1 did we miss? I don't know myself, because we hardly test. Biofire assessment is very expensive, and the protective post-vaccination influenza titers are good. I'm just going fast because we might not have time. Papilloma virus. This is something concerning. We have to ensure that our people are HIV infected individuals are vaccinated against HIV. Now we've got 9 valent. Okay, but it's well proven amongst all the vaccines, well proven to prevent malignancy in the cervix. Now it's very effective. Even in HIV, this vaccine is licensed since 2008, but it is not part of our policy. WHO has stated it, cancer cases, 32% global burden is dead in India. 100,000 deaths, more deaths than what we have in HIV. But even papilloma virus vaccines, there is no government position to launch or include the national immunization program. This is sorely lacking. Now we go to the principles and challenge. This is the principles, let's understand. Vaccination is associated with HIV vital of transgender reduction in CD4 count. Avoid live vaccines less than 200. Polysaccharide vaccines elicit poor antibody response. Then extra booster, but you want to give it. Okay, because there's hard evidence, no. But if you want to give it after your CD4 cells comes out. I wrote this book, we wrote this book in 2014, and then we actually copy and paste of WHO, BIBA, CDC, ACIP, everything. Only difference in India was Kumbh Mela and ideal test and matches. What do we give? Okay. Now we have the consensus on adult immunization for HIV infection and other immunocompromised conditions. We have chosen this. This is what we have chosen for HIV. Okay. And I can go through anything. Shingles is very expensive. Vaccine, 8,802. The last part is implementation science. You have to have a method how to promote the use of vaccine. Now this is my wife. She's a pediatrician. She makes all her children into cushions, including my grandson. And this is her handwritten notes of all the vaccines that I have. Adult medicine, zilch. We don't make any note of what we do for our patients in terms of adult immunization. Okay, so the National Childhood Program in immunization is excellent. We must understand that the benefits are there for vaccination, no doubt. Since Edward Jenner's time, we know that why vaccines are likely to work, and a lot of direct and indirect benefits. And I speak to the population on Alzheimer's disease. So vaccination prevents Alzheimer's. I'm not saying it prevents. It's shown that multiple vaccinations can reduce, can probably mitigate the buildup of toxic proteins. That's what I read. Then we go on to immunization. Why adults don't take the immunization? Fear needles, we don't need it. Now finally, proper storage. This is what we can't have. Please ensure that the vaccines are stored properly. Please ensure that you give the injections properly. You just heard about it in the long-acting ARVs and quantitative and qualitative effects are there in HIV. To patients less than 200 CD4 count, avoid live vaccines, and do not miss the opportunity to give them this vaccine. Then I was the dean, yes, my chief of microbiology came and gave me the vaccine and the vaccine. Now I'm no longer the dean, there's nobody to give me the vaccine, so but I managed to go out and buy for myself. Thank you very much for your patience. What happened to the chairperson? Somebody has to close the session.
Sorry about this. We apologize profusely for this, but the Chief Minister is supposed to be around the corner. Any questions, please? Please, if you could, can you please find a speak? Can you come close? But can you make it quick? Thank you very much.
So I might be the most junior doctor over here. I'm a resident doctor. Yeah. So my question is about HPV vaccine. Why it is not in national immunization program, and especially when we are talking about a person living with HIV. So why it is so much important? Does it need like a booster dose after 6 months, after a few years or something?
She's talking about the HPV vaccine.
HPV, human papilloma.
HPV vaccine. So, are you asking about booster dose?
Yeah.
First of all, why is it not in the national screening program?
Yeah.
Question, please, first.
I'm also wondering why it is so.
Can I answer that?
No, sir, yeah.
Can I answer that? Because, oh, sorry. Please.
Let me give you all the national perspective. So in India, the Serum Institute and Bharat Biotech are working for an Indian version of the human papilloma virus vaccine, which will be very cost effective. And the Ministry of Health under the Child Health Program has already committed to the Cabinet and the PM that they will launch it for the adolescent girls maybe the next financial year, so that is online. So it's only a matter of time. And the phase 4 clinical trials are already undergoing. ICMR has already initiated the phase 4 clinical trials. So we expect that it will be launched for the adolescent girls, specifically the first in the coming financial year.
Can I ask, is there a catch-up plan?
Madam, I am not the right person to answer on the catch-up plan and all, but this is what, because when we attend the meetings and all, because that is a separate national program, but it is online and it is a commitment by the Health Ministry to the Prime Minister.
Can I ask, are you considering HIV positive young girls?
Those what Professor Mathai outlined, that the taking into account the CD4 count and all that, that will be worked on later on. But the priority target will be the adolescent girls.
And MSMs are not being considered.
That will be working out later on.
Later. Thank you very much. Thank you, Dr. Das. They're in the pipeline. Any other questions? Any? Yes, please. Would you mind coming to this mic?
Thank you. Just one information. In Bihar, it is already rolled out for 9 to 14 years girls. They are given given free of cost this vaccine. Thank you very much.
Thank you. Any other questions for Dr. Mathai, please? No? Any questions for Dr. Mansoor? Anything? Any questions? Any statements? Sorry? Yeah, to Dr. Mansoor.
Thank you for that wonderful question. I saw Dr. Leela sitting here, but I don't know if she's there. Okay. So you mentioned, very nascently you mentioned about some STIs during your presentation, but there was no data on that. And then again, there was no any mention about condom use too. So I don't know, like, do you have any data on that, please? Thank you.
Yeah, so in these clinical trials, because this is a phase 3 clinical trials, you normally enroll at-risk populations. So it's expected that you get STIs. The STIs are not caused from using the study drug. It's caused because people are practicing risky sexual behaviors, right? In terms of information about condom use, we never, ever tell a person not to use a condom. Even with PrEP, we never, ever say that. We say, go and practice your life like you've been practicing. Because that's the beauty of clinical trials. The only variable should be the drug. That's the way you test it. So some would use condoms, some wouldn't use condoms like they would in normal life. Yeah, the details of it, if you want the data, they're all in the papers that I put the QR codes up.
Thank you for that QR code. My only statement was that, whenever we talk about PrEP in India, we always say that India is not ready for PrEP. The reason is that there is we call it syphilis tsunami. I'm Dr. Sam. I represent the AIDS Healthcare Foundation, which is AIDS of India AIDS. We have seen, and we treat around 5,000 patients free of cost. One thing that we are observing is the tsunami of STIs. Just because they are deeming it as a pop-up pill, a party pill. When you want to post-sex, have sex, they just do one and then go and have sex, and then the STIs are like galore. I mean, all over the place. I mean, I'm sure a lot of us will agree to that. And then, when presentations like this happen, always the question is, I understand the trial and the methodology that you follow and the cohort that you're following. But again, in a conference like this, at least we could talk about condom and condom use in the community. So that's why I wanted to kind of know. If you have any data on that, I'll be happy to kind of look at it. But I get the point that that's the population that we followed with the same behaviors to be followed even before PrEP, before Lenacapavir, or even if PrEP and all that. So thank you for that. Yeah, thank you.
Sure. So just to add one more, your points are all excellent, and I think this is why after we do phase 3 studies, we have to do demonstration projects and implementation projects. Because 100%, if you give somebody, say, something that's going to protect you from HIV, it's going to turn into a party drug if you're not a responsible person. Our counseling has got to be top-notch. Our, people, our clinicians, our pharmacists, everyone in this room has to get their counseling right. That this drug protects against HIV, not STIs, not pregnancy. So I think it's a two-way street. It's the person and it's the healthcare provider. But without implementation projects, so even in India, I really want to encourage implementation projects, demonstration projects to really see what the real data is.
My last statement would be that I hope Gilead and all the other 3 pharmaceuticals who got license to make Lenacapavir packages it along with the condom. Thank you.
Thank you.
Done?